morning and welcome to the Central Breakout. My name is Carolyn White and I'm a retail food specialist with the Office of State and Cooperative Programs, and I'll be one of your moderators for the session today. Retail food specialist Becky Steiner will also be joining me as we welcome our speakers. We are really excited about the agenda plan for this morning. So to give opening remarks, I would like to give a warm welcome to Kimberly Destrom, our director for Branch 2.
Well, good morning, everyone, and welcome. Give me 1 second here to share my screen here. Let's see if this works. I tested it, but sometimes, as you all know, it doesn't work the way it is. Okay, so we're seeing the right screen, right?
Yep, looks good, Kim.
Okay, thank you so much. Well, welcome, everybody. I'm just going to rearrange my screen so I can see my slides here. As Carolyn mentioned, I am Kim. I am the branch director for Branch 2, which some of you may recall, although it's been a while since we've been in regions. Branch 2 covers most of the states of the former Central region. And once again, this year, I'm very honored to have been asked to provide a few opening remarks for this breakout session, and as well report on the State of the Union. And the union of which I'm referring to is the FDA and all of you who are our state, local, county, city, and tribal public health agencies who are responsible for protecting our consumers and our citizens within the US. So this year, I do want to speak a little bit about the progress that we have made with the new era for food safety. As many of you know, this is our new initiative that was started by Frank Yanis when he came on board. And we're doing a lot of great things. So I'll talk a little bit about that. But first, I'm going to change things up on you a little bit. I know in the agenda, it says I'm going to do opening remarks and then recognition, but I did want to go through some recognition first because it's something that is very near and dear to my heart. So if you don't mind sharing in some of the successes with your fellow central states, without much ado, giving a little bit of love to our former central region states here. You all work extremely hard. And so I just want to mention a few highlights that have happened over the last year. Starting out from the west side, I do want to give a shout out to North Dakota. Some of you may not have known that North Dakota moved to a direction where they have mandatory state standardization for their delegated local health jurisdictions. And this is actually really exciting for us to find out about because this kind of policy and program really drives uniformity and consistency with public health programs. So congratulations, North Dakota, for moving in that direction. We're very supportive of that. I also want to mention that over in Minnesota, and even though I'm from Minnesota, I'm not biased at all about the great work that Minnesota is doing. But I do want to mention that Minnesota has moved in the direction of translating a lot of their food safety materials into languages that many of us may not be familiar with. They recently updated some food code documents into Somali. And I believe that this is the only state that has translated food safety materials into Somali. And I think they also have some other languages, including Hmong. And this is just really exciting work because this type of innovation, it is the kind of thing that we need in order to spread the message about public health to as many people that are working in the industry. So congratulations, Minnesota, on the great work there. I also want to send a congratulations to Mr. James Mack in Wisconsin, who was their retail program standards coordinator, who retired this past year. You've done a lot of great work and you are going to be missed, but congratulations on your retirement and we wish you all the best. I also want to congratulate Dara Dunlap, who is the new program manager for the state of Illinois. We are very excited to have you on board and we're looking forward to working with you. I look forward to meeting you as well. And I would be remiss if I didn't mention Becky Vaught over in Michigan. Many of you know her because she is this year's CFP conference chair, among many other things that she does. But she has also been appointed the new Local Health Services and Emergency Response Manager for the Food and Dairy Division. So congratulations on your promotion. We're very excited for you. I also want to congratulate Mr. Daniel Bell, who was recently promoted from the Food Safety Branch Manager to the Assistant Director of the Division of Public Health Protection and Safety at the Kentucky Cabinet for Health. Congratulations. Very excited for your promotion as well. And also, I'm very excited that Ms. Alicia Page has been hired as the new Retail Program Standards Coordinator at West Virginia, which I know that they are very much looking forward to you coming on board and working with them, and all great work in West Virginia. And I am also rooting for West Virginia. They are very close to meeting all 9 standards from what I'm hearing through the grapevine. So we're looking forward to your success there as well. And then in New Jersey, I also want to congratulate Mr. Bill Manley on your great career with the New Jersey Department of Health and your retirement this past year. So congratulations, you will be missed. So thank you all very much for your work and congratulations on your successes. I also want to mention, give a shout out to our brand new standardization officers. As you all know, standardization is not an easy feat. It is a test of your ability to conduct quality risk-based inspections against the FDA food code at an equivalent level to an FDA retail food specialist. So not exactly a walk in the park, but those that are able to accomplish this and maintain restandardization, it's a phenomenal program that really helps drive towards uniformity within your state. So as you'll see here, Leslie, Shane, Sherry, and Kara, congratulations on becoming new FDA standards with us. We look forward to working with you. And those of you that have been re-standardized, and there are many of you, congratulations to you as well. The work is just beginning, and we really look forward to having that relationship. So congratulations to all of our new FSIOs. I also want to get into some congratulations for program standards. Retail program standards it's a phenomenal program that we are really excited about. We really support this, and we want you all to know that if you are interested in advancing within the program standards as a way to improve your program, please reach out to your specialist, and we want to provide you all the support you need as best we can. There are a lot of great things that happen, and I do want to go through some accomplishments over the last year. This list is long, which I love to see because it means that you all take this very seriously and you want to make a difference. So without further much ado, we have some new enrollees to the program. I have 2 slides here, so I'll go through them, and I'm not going to read all the names just because there are a lot of names, but I know you guys can take a look at them. But I do want to give some recognition to those that have recently enrolled. This is a big step, and you'll see that there's a lot of local health departments on this list. It is for a lot of the locals, as you know, some of them can be very small organizations, very small, sometimes 1 or 2 man operations. So that's a lot of work. So congratulations to you for taking that first step. We're excited to work with you. And there are many jurisdictions that have completed their full assessment of all 9 standards, which again, is not an easy process. Our requirements are for a year. Sometimes it can even take longer than that. It's a lot of work, a lot of assessment. So congrats for taking that step. You are on your way, and we're really excited about this. I also want to shout out to those that have met either by self-assessment and verification audit standard 1. This, of course, is our adoption of the FDA food code. So it's called number 1 for a reason, because it is such an important foundation to have within your jurisdiction. So congratulations. We also have recognition for standard 2. This is a tough one. There's a lot of pieces here. A lot of training involved, so congratulations. And those that met either by self-assessment or verification audit standard 3, congratulations to the hard work you put in. And then we have standard 4. Again, a lot of great work has happened in the program standards. It's an ongoing process. It's not easy. And of course, there's standard 5, which is another tough one to meet, a lot of paperwork. I'm really looking forward to hearing the presentation about the complaint system later today. I think that's going to be really interesting. And standard 6, another tough one. Congratulations to your work on this standard. And standard 7, which is, of course, our industry relationship one, which is so important, especially this day and age. Industry is our partner, very much so. Congratulations. And standard 8, Minnesota Department of Agriculture. Great work. This is a very tough one to meet, very tough, and you've done great job. And of course, standard 9, which is our public health metric. I just want to give a big congratulations to everyone. Please share it with me, and congratulating to those that have had great achievements this year with program standards, with their program in general, with standardizations, and with great careers that they have accomplished. So with that, I do want to move on to let you know about a few updates, or not even updates, but some awareness just so that you have, for those of you that are not aware, I'm sure most of you are, because we have definitely been shouting from the rooftops. Our funding program is now open. It's been open for a while. We have a few more weeks left to apply. The portal closes October 12th. So if you're interested in getting funds to help you achieve any program standards accomplishments you're looking to do in the next year, I encourage you to apply. You can reach out to your retail food specialist to discuss what types of things might work for the grant program. You can also reach out to NEHA with any questions in regards to applications or any of the more technical information on the portal. I will just mention that this year there's funding available for conducting a self-assessment and a strategic improvement plan, as well as some other options if you've already completed those. If you want to get money to work towards progress within a standard, there's money available for training if you've already done a self-assessment and a CSIP, which is the Comprehensive Strategic Improvement Plan. And I believe there's also funds available for special projects. So I also just want to put a little plug in for CFP. We're coming up on a CFP year in 2023, and you are eligible to apply for funds to get you to CFP, you and yourself or someone within your jurisdiction, using the training funds, I believe. So look into that if attending CFP, which I strongly encourage, is something that you might be able to do in this next year and you're looking for a little financial assistance. All right, I also just want to put in a little plug for our training needs assessment. I know many of you have seen this out and about. It's been mentioned in a lot of presentations, so you're going to hear it again now. I believe there's also a banner on the seminar website, and you can even take your phone right now because there's a little QR code you'll see on your screen. You can just scan that right now if you want to take it. It takes about 20 minutes, but honestly, probably a little bit less. I do want to mention that this is something that NEHA is putting out, but this is a training needs assessment for FDA. And the reason why we're asking for this information is because we are looking to improve our training system and making sure that we are offering the training that's needed. So we want everyone to take it. It doesn't matter what level or where you are within the regulatory system. If you are doing regulatory work in food safety at any level, we're asking for your input. So I encourage you to either use the QR code or you can go to the website at NEHA and take this survey. All right. I also just want to mention, if you weren't aware, that we have released the most current retail program standards manual. It is now on the website, and there are changes, significant changes, I would say, to standard 2, 6, and 8. And those reflect updates, recommendations from the 2021 CFP meeting, the Conference for Food Protection. So if you are working or planning to work on those standards, I would encourage you to check those out. There is a summary of changes available. You can also reach out to a specialist with any questions, but that is now available for you to download and review. Speaking of program standards, I'm also very excited to announce that again in 2023, we're going to be offering 4 self-assessment and verification audit workshops. These are available for regulators. We have 2 in person. They're going to be in association with the AFDO AEC and NEHA AEC. They will be pre-conference workshops in advance of those 2 events. And those are going to be in the summer. And those do have a cost associated with them. Again, depending on if you're interested in applying for funds, you can apply for grants in some cases to attend those. I also want to announce that we are offering 2 virtual instructor-led workshops, so completely online in the winter. And the best part of this is we have made it possible so that these are going to be offered at no cost to regulators. We worked a little magic to find a way that we can make these fully available. So we're really excited about that. If you are interested, registration is going to be coming out very soon. I do want to mention that though, both for the virtual and the in-person, we do have a limit of 2 people per jurisdiction that can attend those courses. And that's really in order for us to maximize accessibility options for as many jurisdictions as we can, because the course numbers are limited. Unfortunately, we cannot fit thousands of people in those courses. But if that's something you're interested in, I encourage you to look into that. We also have our online self-directed SABA modules. We have, I believe, 3 that are on OTED's learning management system currently. And we're planning on having the remainder posted within the next year. So that is completely free and available to you if you are a regulator. So we're very excited about that. And now something that I personally am very excited about is going back into person. And we have been working on a transition back to in-person over the last year. And I think next year it's going to be our year. I'm really excited. I hope you come and visit me in Houston in April at a conference for food protection. I will be there as well as our specialists. So please, if you have the opportunity to attend, it's one of those meetings that is probably, in my opinion, has been the most impactful for my work within the retail world and the work that I do. If you're fans of Hamilton, you want to be in the room where it happened, that would be CFP when it comes to retail. So I encourage you to attend if you're able to. And even if you're not able to, our team is going to be working with you all on getting you ready and understanding the issues, having coordinated calls to discuss the issues when they come out. So stay tuned. That usually happens, I believe, early in the year. I want to say February, March time. So stay tuned. It gets very exciting. And I'm also very excited to discuss next year's retail seminars. This is the third year we've been virtual, and I think that we're all ready, well, most of us, to see people in real life again at these events. So we have made the decision, we're planning to do face-to-face in-person FDA seminars next year, which is very exciting. Things may look a little different than they have been in the past. It's been, it's been 3 years since we've been in person, but actually it's also been about 5 years since FDA moved away from a regional structure. So our seminars won't be regional affiliated anymore. Which I think is a good change. We also want to make sure that our seminars are open to everybody and not limited to only states. So that's one thing that we're looking at, is making sure that the seminars, anyone can go to the seminars, and we want to make sure that they're open and available. So we're really excited about that. We're still working out locations and options, but more to come on that. So stay tuned, and I hope that you can join us all at one of our seminars next year. All right. So now I do want to switch gears a little bit and talk about New Era. The New Era of Smarter Food Safety is our primary initiative within the Foods program. We're doing a lot of really neat things here. We get a lot of speaker requests on New Era. And so I did want to just talk a little bit about the work that's being done on the retail side, if you are interested. Now, you may or may not know, New Era has 4 core elements, which is what they're called, that we're focusing on. The core elements being tech-enabled traceability, smarter tools and approaches for prevention and outbreak response, food safety culture, which we know is a big one, and then of course core element 3 here, which is our new business models and retail modernization. Now, all 4 of those core elements impact retail. The food system, as you know, is not really divided in the way that it used to be. But there's a lot of blending, but retail, the new business models and retail modernization is really the core area or element where the retail team is leading. And these 2 bullets here you see, it says these are our sub elements, if you will, ensuring safety of food produced or delivered using new business models. This is our e-commerce platforms that we're looking at, which we're looking at as new business models, which we can talk about whether they're new or not, but the technology has really advanced. And then modernize traditional retail food safety approaches. So the lines, as we know, are really become blurred. We don't have just a bucket of retail food safety and then a bucket of manufactured food safety. Those buckets have spilled and it's just a big pool in the middle, right? And there's no clear lines anymore. And so we really have to navigate that and look at, is what we're doing and what we've been doing really meeting the need of retail food safety today? So taking a look at all of that. Now, when it comes to e-commerce, we have a little slide here about the grocery business. And I expect that 20% has actually gone up, because this slide was from a few years back. It says by 2023, it could reach 100 billion, but it's a huge growing market. And in fact, I suspect that most of you are not always going into a store to buy your food anymore. It's become such a convenience. But as you all know, as regulators, this is really challenging because how do we navigate this new area where food is being manufactured, but it's retail, and then it's being shipped, but who owns it? And so we had the e-commerce in 2021, and all of the response, we had great response and a lot of comments that came back. Really, the question is, who owns the last mile? And so FDA is going to be investigating and coming up with recommendations. One of the primary areas they're going to be investigating over the next year is the regulatory landscape. Where do FDA regulations end and the state and local regulations pick up? Where is that line defined? Are there gaps that we have to address? And if there's gaps or there's no regulatory oversight, how do we address that? So that's the approach that FDA is going to take. So we're going to hear more about that in the next year. And I know you all are looking for answers because we are too. There's been a lot of situations that are confusing and trying to get clarification. And so that is where we're going to be looking at when it comes to e-commerce. That's our next step. So stay tuned on that. When we talk about modernization, again, there's a lot of things we can do here. There's some bullets I have here on the screen where we're looking at the effectiveness of the programs, risk-based methodology and root cause analysis, food safety management systems. One of the things that we're going to be looking at is we're looking at getting an outside contractor that has no affiliation with the retail system to do a nationwide US assessment of the entire regulatory landscape, looking at what's working, what's not working, where we can make improvements, and what we need to expand. And this is going to give us a lot of information. You know, a lot of times when you're in the middle of something, you're too close to really make an honest assessment as to what's working and not working because you're dedicated and you're into it. So we need someone outside to really take a look and help us identify those things where we have blind spots. We've been doing the same things year after year after year, but yet people still don't wash their hands, right? So how do we address some of those things? What else can we look at? One of the big areas we're starting to investigate is behavior change. This is not a traditional way that we look at food safety, but we need to change the people practices. A global pandemic didn't change hand washing behavior. So what does it take? So it's going to be really interesting. And we're working with human behavior experts. These are people that have degrees in psychology and sociology. It's not food scientists, right, that always have the answers that we need. So we're branching out and looking at other ways that we can do things. So I think this is really exciting. And there's a lot of options and opportunities here. So modernization is definitely something we are looking at, but that the results from the independent review are going to provide us a lot of information as well. All right. So the road ahead for core element 3, FY23 and beyond. One of the things that we've been focusing on a lot is our collaboration. We cannot do this alone. We really can't, and we've known that, and we're taking steps now to ensure that we are working hand in hand with our partners. We have the association Cooperative, which is working together on some of these initiatives. So we're all taking a part of it. And that word they use for that, of course, is synergy, where the individual components together are more than the whole. And that's what we're looking for. If we're all working towards the same goal, we can make a difference. We're looking at a national food code strategy, a national adoption strategy, a way to impact the improvement and increase in risk-based inspections at retail, better training and improved resources for outbreak response and investigations, and of course, active managerial control. And food safety culture, we can't force culture onto anyone. As you all know, culture is really a top-down initiative. So we're working with industry partners, and we want to work with industry partners to make the changes in their own houses in partnership, because you can't regulate culture, as you all know that. But what we've shown in our studies and other people's studies and a lot of research is that if the culture is demonstrated by the management level within an organization, it carries forward. And so that's where we want to go with that. Active managerial control, food safety management systems, improve food safety culture. So with that, I actually got through a little bit earlier than I anticipated, but I want to say thank you And I hope to see you all next year. I'm really looking forward to the next year in food safety. Thank you all.
Thank you, Kim, for introducing us for this central breakout session and giving us an excellent kickoff for the morning. And we're going to get started with our first session presentation today. We're going to have Nicole Hedin from Minnesota talk to us about a survey of Minnesota food workers. The Minnesota Department of Health surveyed more than 1,500 food workers to better understand how workers want to receive food safety information, their views on health department inspections, and their behaviors pertaining to illness reporting. The responses from the survey will be used to inform how future communications, trainings, and resources are delivered. Nicole has been an epidemiologist at the Minnesota Department of Health since 2010. And she helps develop research studies, collects data, and analyzes data with the goal of identifying and preventing environmental factors contributing to foodborne illness. She also leads the foodborne outbreak investigations and is a registered sanitarian. All right, Nicole, I will go ahead and turn it over to you.
Hello, can you hear me okay?
Yes.
Awesome. Well, thanks so much. I'm excited to be here. Good morning to everyone. And thanks to Greg Abel for inviting me to come and speak. But yeah, I'm going to talk about a survey that we did in Minnesota, and it was kind of a survey to assess some perceptions and beliefs and behaviors of food workers in Minnesota. And hopefully some of the survey results and just the questions and stuff might give you some ideas if you're looking to do a similar type of survey for your own agency. So first, I'm going to talk about Minnesota in general and just how we're set up when it comes to inspections and the health department, and also what we currently had done for operator outreach. So the population of Minnesota is just under 6 million, and the Minnesota Department of Health has 7 district offices scattered throughout the state, and we license approximately 14,000 food pools and lodging service establishments. Now, the Department of Health has delegation agreements with local agencies, so cities and counties that do their own inspections, and we have 28 delegation agreements. And for those 28 agencies, they also license about 14,000 establishments statewide. So the state is really kind of split 50-50 between locals and state jurisdictions. And we do have a number of meetings and trainings each year where both state and local regulators can really kind of get together to network with one another, but also to learn about new issues in the food safety world and talk about maybe things they're seeing in the field. And we also work closely with our epidemiologist partners since we are centralized when it comes to outbreak response. Now, the team that I work on is called the Partnership and Workforce Development Unit. And you can see all of my teammates pictured here. Angie Wheeler is our state program administrator. Kim Carlton is my direct supervisor. And then all of my wonderful colleagues, Sophia, Michelle, Sarah, Denise, and Jim. And so our team was actually created in 2006 and is funded in part by a statewide hospitality fee that was approved by the Minnesota legislature in 2005. And the fee is used to really ensure a safe and secure hospitality industry. And so some of the things we do is train state and local delegated inspection staff. We provide technical assistance to local agencies. We conduct program evaluations, coordinate foodborne and waterborne outbreaks, and really produce educational and informational materials for industry and also for public health partners and the community. And we also have an emergency notification system. So we have a lot of things that we offer training-wise and outreach-wise, both internally to our inspectors statewide, but also externally to operators, public, academia. So since one of the tasks we have as a team is to provide educational materials to our industry partners, we have a number of different ways we provide operator outreach. Pre-COVID, we had 4 kind of main ways that we engaged operators. The first is kind of through what we call our Gov delivery system. And this is basically a email subscriber list where we can push out like newsletters or just updates. And it began around 2010. And in the beginning, it was pretty slow to start, and it was mainly for just like occasional messaging, maybe for meetings, or if there was licensing changes, or just to message the certified food manager instructors, their subscriber list. So not used a ton, but we kind of really picked up our use of the system in 2018, and 2019. We sent out more than usual newsletter updates just because we are rolling out a new food code. Our new food code was adopted January 1st, 2019. And so we really wanted to kind of let our operators know what the process would be for the, adoption of the code, and then also highlight some of those major changes so that they would really be aware and able to implement those new requirements in their facilities. So in 2018, we sent out 15 issues, and in 2019, 17 issues. So our Gov delivery system, we can actually reach thousands of subscribers, and you can filter out like what group of subscribers you want to reach. So you'll see that with who we sent our survey out to. We did pick a few different subscriber lists for that. And then presentations to the industry each year, we have a handful of presentation requests, and those usually have been in person. And again, kind of when industry reaches out, I've presented a few different times, maybe to more corporate restaurant chains where they want to know about outbreak detection in Minnesota and what we do during an outbreak investigation. And I know some of our inspectors, provide just kind of general food safety information to different groups as well. So that's on a upon request basis. And then we have our food safety partnership. And this is a group of basically EH professionals, industry partners, academia that come together. And we have a committee that decides kind of what maybe some hot topics or new ideas for trainings that we could hold. And so we have these meetings twice a year. And the meetings were attended by a number of different stakeholders. Again, EH professionals, industry partners, academia, and even the general public. We held most of these in person, but in 2018, we also started using WebEx and live streaming them. And I would say we usually had about 150 to 200 people in attendance. So a great way to kind of get information out on new research or just new food safety topics. And then, of course, our inspectors do inspections statewide, and that's a great opportunity to kind of provide education and training one-on-one to operators. Obviously, this process really varies by agency and inspector. So then COVID hit, and everything changed as it did for everyone else as well. So really kind of March 2020 to March 2022, most of the outreach that we did was halted, at least for a chunk of time. We didn't do any of the really FSP trainings. We didn't do any of the, of course, in-person trainings to industry. And then March 2020, our restaurants in Minnesota were closed and could only do takeout service. This was in place for a number of months. And then once summer hit, they could do some outdoor seating. But of course, management of both state and local agencies were concerned about the health of inspectors and making sure they were safe. And there were so many unknowns. So for a while, there was no inspections that were being completed. So really the main way we were able to provide kind of operator outreach during this time was through our Gov delivery system. So in total, from this 2-year period, we sent out 36 issues of updates via Gov delivery to operators. Of course, most of this was providing, some of that routine updates and guidance on those COVID prevention measures to make sure that they could operate safely for their employees and the public. So you can see we have a number of different avenues on how we provide information to industry and operators, but we never really have evaluated our methods. So in my position, I'm the Minnesota Environmental Health Specialist Network Coordinator. So SNET for short is a grant. It's funded through the CDC, where state and local agencies really work together to conduct research studies looking at foodborne illness risk factors. So part of this grant, we have to do individual site projects So before COVID, I was really kind of brainstorming ideas for my Minnesota SNET project. And we had the idea to survey operators and just ask for some of that feedback on how they receive food safety information and really kind of their preference for receiving information. We're also curious about behaviors pertaining to illness reporting and other Minnesota specific code requirements, since norovirus is responsible for about 50% of our outbreaks. Of course, then COVID hit, and things kind of took a back seat for a little bit. But during that time, we really had heard from kind of the inspectors that relationships between operators and inspectors were really tense and strained due to kind of closure orders and other COVID prevention precautions that were put in place by the governor's office. So I was definitely interested in understanding how operators perceived inspections and how their relationships with inspectors were. So these questions and kind of finding the answers to them became our 3 main survey objectives stated here. So for the survey, our audience was workers in food and beverage service facilities. And we did include in parentheses here delis, coffee shops, bars, and restaurants, because we didn't want someone, reading that for workers in food and beverage service facility to feel like that wasn't them if they worked maybe in a bar or coffee shop. So we did call that out as well. We created the survey in Microsoft Forms, which worked really nicely. It was a 29 question survey, and a lot of the research I had done said surveys should take 10 minutes or less in time. So I was really kind of aiming for that. And one of the nice features in Microsoft Forms is that every time you get kind of live feedback, every time someone completes the survey, it shows the average amount of time it's taking participants to complete all this or the survey. So it took 7.5 minutes, which was good because that was under our 10-minute goal. And we distributed the survey via social media, Facebook and Twitter, and also our Gov delivery system. And the survey was open for just over a month, February 21st through March 25th of this year. So you can see here kind of our different distribution methods and what we wrote to the public. So this first post is via Facebook, and it says, Minnesota food and beverage service workers, we want to serve you better. If you work in a coffee shop, bar, deli, restaurant, or other food establishment, please take our anonymous 10-minute survey. Included the survey link. Your answers will help us understand how you want to perceive food safety information, what you think about food safety inspections, and your perceptions of employee illness. We'll use your feedback to improve how we send out food safety information, trainings, and resources. Thank you for your help. So that's what we included on Facebook. And then you can see on the right side, our tweet was much shorter. And then in the middle is kind of our Gov delivery message. That was definitely a little lengthier. And we did include some other updates in that bulletin, which you'll see in a minute. So here's a summary of the distribution reach via Gov delivery, and this was taken within kind of the first 48 hours that the survey was live and sent out. I will say the majority of the responses kind of occurred within those first couple days. And so we can, like I said, actually select which subscribers we want to send our Gov delivery message out to. And so you can see the 2 lists that we selected were subscribers of Certified Food Manager updates and subscribers of our Partnership and Workforce Development Unit and Food Safety Partnership. So in total, it went out to about 30,000 recipients. And then looking at just kind of as you go down, about 12,000 actually opened the email. And then we had 2,200 clicked on links within the message. Now there were 7 other links included in the bulletin that we sent out. So you can see here that there was that first link is the Microsoft Forms, and that's the survey. So we had 714 unique clicks there within that first kind of 48 hours. If there is an email address on multiple subscriber lists, the system actually cleans it out so we don't send duplicate emails. So that 30,000 recipients is pretty accurate. And then here's kind of a summary of the distribution reach for social media outlets. So again, we advertised to Twitter and Facebook. So I'm not super familiar with Twitter. This is kind of new to me. But basically, Twitter, I guess, uses impressions, and that's a total tally of all the times the tweet has been seen or liked. And then engagements are the total number of times the user has actually interacted with the tweet. So for example, clicked on the survey link. So you can see here, we didn't have a ton of engagement, just the 20 clicks here. And then this is our Facebook post engagement is the total number of actions that people take involving your post. So you can see 386. And then link clicks, the 343. And you can see some reactions, some shares, some saves. So definitely Facebook was a better route to get the survey out versus Twitter. But our Gov delivery system was really, I think, where we got the majority of our responses. So in total, we had 1,659 responses, which was extremely exciting. My goal for this for participants was to get 150. So it was pretty fun those first couple days as we were seeing, the responses and the survey completion rolling in. Our team, kind of kept checking in and we're like, oh, we're at 700, we're at 1,000. So that was pretty cool. So the first question on the survey asked, do you work in a food and beverage service setting? And if you said yes, you continued with the survey. So there was 1,535 that continued. And if you said no, the survey ended. So there's 124 that were excluded. The main kind of age range, I would say, is definitely 31 or older. So a little bit more of a seasoned crowd, more experienced, not as many 15 to 30-year-olds taking a survey. And then we asked, what is the primary language that you speak? And the vast majority was English. We had, I think, 29 that said Spanish was their primary language, and then just a handful that reported Chinese, Hmong, and Vietnamese. So then looking at, what are your primary job duties? So you can see most respondents, or the majority, were managers or management level, followed by food prep, cooking, and then front of the house. And then asking how many years have you worked in food service? You can see most have worked in food service for more than 15 years. So again, kind of a more seasoned, experienced work group, which makes sense if most of them, are kind of at that management level. We then wanted to know about their training and experience. So 88% have been a certified food protection manager at some point in time, but 92% still had a certificate that was valid. So again, kind of going along with the fact that they're more experienced, more managers, and then most were employed in their current position for 1 to 5 years, that was 33%. But then there was quite a few that said more than 15 years as well, 26%. So again, most being trained, having that valid certified food protection manager certificate makes sense since, their management level. But interesting that most were in their current position for 1 to 5 years, suggesting maybe movement or turnover. But there was, like I said, a good chunk that had been in their positions for more than 15 years as well. So then we wanted to ask about how they receive food safety information. So our first question on this topic is, where do you get your food safety information? And you can see the majority stated that they get it from a certified food protection manager course. So something like ServSafe. Obviously, there's a plethora of different courses that are offered statewide, nationwide. But then the second highest response was they get their food safety information from their health inspector. So that was pretty cool and kind of surprising and exciting. And then followed by classes and trainings, and then health department websites and electronic newsletters and websites. So then we asked, what is your preferred method to receive information? So the top answer was via email. So newsletter newsletters and updates via email. So that is good to know just because, like I said, that's how we're doing our Gov deliveries, go out via email. So it's good to know that that's kind of their preferred method. And then that was followed by online trainings and presentations. In-person trainings or presentations was kind of the third highest option or highest response. And then conversations with health inspector was up there too. So again, that was really exciting and interesting to see that, that health inspector relationship is important to operators. And websites, mail flyers, social media, and definitely not as popular. So then we asked in the past 12 months, which of the following resources have you used to obtain food safety information? And the top response was the Minnesota Department of Health website. And this definitely makes sense just because it was, kind of peak COVID time. So they're probably looking for a lot of direction there. But then the second top resource was asking their inspector a question in person. So again, that inspector relationship really critical and important. And then followed by looking at local health department websites or emailing inspectors or in an inspecting agency a question. Then we asked the respondents what kind of what food safety topics do you wish you had more information on? And you can see here the top choice was food code requirements, and that was closely followed by food recalls or consumer warnings. And then general food safety was next. And then kind of the fourth option was food safety for new food trends. Equipment requirements was a little further down on the list. And then as an epidemiologist, I was sad to know that foodborne illness prevention was the last pick or last choice. So I see outbreaks all the time, and I feel like that's really important. But I guess our industry and operators don't feel like it is important, or maybe they're not aware that there are outbreaks going on all the time. So then we wanted to really get at kind of their perceptions of inspections and how they view their relationship with inspectors. So the first question we asked was, in general, how beneficial are health department inspections? And it was really overwhelming response for either very beneficial or somewhat beneficial. About 89% picked one of those options. Only 5% said not at all beneficial. And then when asked, is there anything you would want to change about your inspection process by the health department? 70% said no, nothing they would want to change. 17% said yes. And there was 12% that said, I'm not involved with health inspections. So the majority wouldn't change anything about the process. So then for those that said they would want to change the process, we asked, what would you want to change about that process? And this was an open-ended response that they could provide. And these open-ended responses have not been fully qualified or quantified, sorry. But I went through and looked kind of at like the frequency of responses and if there was response groups kind of that were coming up. And so I summarized them here. And there was a number of responses talking about having a scheduled inspection or some kind of like, can we have our inspections? Can we make appointments? Could they be scheduled? Could we be given some kind of heads up so it's not during our busy time? Heads up so we can have the correct person on site. So that was definitely the common theme that I was seeing in those open-ended responses. And another thing that came up multiple times was just really wanting that consistency between jurisdictions, so between state and local agencies, and also between inspectors. Like if there's a change and a new inspector leaves and there's a new inspector, like just kind of those frustrations with inconsistencies there. And then a number of responses talked about how they would really like the process to be more consultative and educational, more of kind of a sit-down meeting, so they can, learn from the inspection. And then there were some comments about more frequent and thorough inspections as well. Don't just, pop in. Some other comments that I didn't include here were, talking with employees, not just the management, to really get at that employee knowledge. And then there was a few comments about getting rid of paper reports and emailing inspection reports out. And I think most agencies are doing that. So lots of good information there. And then we wanted to know, what is your overall satisfaction of your interactions with your health inspector? And you can see here, most were very satisfied or somewhat satisfied. There was only 45 of the 1,535 that were dissatisfied or somewhat dissatisfied. So inspectors are definitely doing a good job just building and maintaining those relationships. Then we asked, how has your relationships changed with your health inspector over the last 2 years due to COVID-19? And you can see here, relationships really, the majority said their relationships were unchanged, and there was definitely more improvement than worsening of relationships. So that's encouraging. And then we asked, describe how your relationship has changed. And this was also open-ended. And a lot of the comments, I asked more questions of my inspector. We had a lot more communication. I received a lot of updates on COVID policies and precautionary measures. But there were some negative comments about I never saw my inspector during COVID, or they just stood in the doorway for a few minutes. And of course, all of us were navigating COVID world and how to do inspections. So, it makes sense that there would be some frustrations by operators. And I pulled out just a few of the open-ended responses. So you could see this first one was, kind of a more negative one. I haven't seen my inspector at all, 0 feedback, 0 interaction, 0 answers to questions and messages I've left on voicemail or in emails. But then definitely some positive ones. COVID has helped level the playing field for many people in our industry. I actually felt like our inspector was on our side for a change. It stood out well when the governor was so anti-hospitality. Our inspectors actually helped us apply our usual safety practices to overlap and protect us all from COVID. And then also health inspections seem to be more outcome-based rather than punitive, much more positive interaction and helpful ideas and information. So again, definitely some negative comments, but a lot of positive and encouraging comments. And I would say that was kind of the majority of those responses. So then we asked, if these operators, if they felt they had enough training to effectively provide food safely to their customers, and 93% did feel they had enough training. But we asked, what would make you more effective in ensuring safe food handling practices are followed at your restaurant? And we listed a number of different options. The first kind of uh, the most frequent choice was having more food safety fact sheets, followed by more communication from the health department about requirements and food code updates. Another option we listed, and that came up as third, was having paid sick leave so I don't work while ill, having food safety videos, and then additional training by the health department or management. We also had an open-ended other response where they could type in kind of what they wanted to include that we hadn't listed. And again, that consistency between agencies came up, and that more hands-on training or consultation from the health department. I included this response because I thought this was really interesting. Defining sick more specifically would be helpful. Is it with a fever? Is it vomiting? And I think all of us can relate to this because it seems like, everyone was in COVID world so much and thinking about sore throat, fever. And I think a lot of people, or maybe operators, really forgot about the vomiting and diarrhea. So definitely an interesting comment here. Okay, so then switching gears and looking at kind of employee illness behaviors and illness reporting. So in the past, we asked the respondents in the past 3 months, have you been sick with vomiting or diarrhea? And 201 or 13% said yes, they had. Keep in mind, this was back, the survey was open and live the end of February, so kind of peak norovirus time. So 13% had experienced vomiting or diarrhea in the past month. So then we asked those 201 individuals, or the 13%, did you tell your supervisor you were experiencing vomiting or diarrhea before reporting to work? And of those 201, 80% said yes, they did report it to their supervisor, but 41 or 20% said no, they didn't. So then we asked, those that said no, I didn't report it. So that was again 41. Why didn't you tell your supervisor you were sick with vomiting and diarrhea? And you can see from the bar graph here, the most common choice was, didn't want to lose my shift, followed by I was worried there would be consequences from management. And I think we've all kind of heard that, concern in past research about just, the consequences of not being able to show up and work your shift, and, really trying to get at that food safety culture to fix this. But the Minnesota Food Code does require reporting of vomiting and diarrhea symptoms to the person in charge. So, that's definitely something we want to continue to educate, those 20% that are saying, no, I'm not reporting it. So, kind of along that line, we asked, does your restaurant management require employees to report when they're sick with vomiting and diarrhea? And you can see the majority said yes, but there was 16% or 242 workers that said no, their restaurant doesn't require employees to report if they're sick with vomiting and diarrhea. And again, management is required, or the person in charge is required to let employees know that they need to report those symptoms as outlined in the Minnesota Food Code. We then asked, if an employee comes into work while sick with vomiting and diarrhea, how does management respond? And you can see the vast majority said they would send the worker home, so that's good. But there was 65 respondents that said management would do nothing. So definitely a concerning thing there. Now, in the Minnesota Food Code, the person in charge is required to track employee illness and log symptoms of vomiting and diarrhea. So we asked, does management at your restaurant maintain an illness log to record employee illness? And you can see here, 75% said yes, but 11% said no. And there was a good chunk, 14%, that were unsure. So then we asked, why doesn't management maintain an illness log to record employee illness, for those that said no? And the top response was that they're unaware of the log requirement, followed by management has a log, but they don't maintain it. And then the next most frequent choice was management is aware of the log requirement, but there are too many other things to keep track of. And I'm sure, anyone that's working in the fields, you've if you have this requirement, you've verified that as well. Either they can't find their illness log or tracking sheet, or if they do have it, it's completely blank. So a lot of issues there. We then asked, what would you do if a customer called and said they became sick after eating at your restaurant? And you can see here the top choices were notify management, and then take down the individual's name and number. Contact your health inspector or health department are requirements in these situations by the Minnesota Food Code, but you can see only less than half said they would actually reach out to their inspector or health department to report that customer complaint of illness. So just going into kind of some of the summary or take-home messages, first looking at just the distribution of food safety information, and how operators want to receive their information. Again, most of the respondents were certified kitchen managers, so it definitely makes sense that many receive their food safety info through certified food protection manager courses. And these courses that are offered in Minnesota, the health department does approve them, so that's good. But there's so many different courses that they can take. And again, it just makes sense that that's where they would get their food safety information. But conversations with health inspectors were the second most common response, which was definitely surprising and exciting. Now we live in an online virtual world, just having this meeting virtually shows. So email updates and online trainings and presentations are kind of the preferred method to receive food safety information. Gone are the days of mailing flyers, different things like that. Even the in-person trainings I know can be difficult now for people that work from home. And then again, conversations with their inspector and the health department website are some of the most frequent resources that are being used to obtain food safety information. So making sure our website is organized and easy to use, that we have it in plain language, easy to find those fact sheets and resources that the operators want. I know Kim mentioned that we have been working on translating documents, so just making sure, to continue that efforts. We do have translations among some Somali, Spanish for a lot of our fact sheets. So that's awesome. And I think helpful to those operators that don't have English as their primary language. So summarizing some of the perceptions of inspections and relationships with the inspector, operators and perceptions of inspections and relationships with their inspector were overwhelmingly positive. For those who would like to make changes to the process, really having inspections that are scheduled or announced came up very frequently, and then having that consistency between inspectors and agencies, so state versus local, came up numerous times in those open-ended responses. Now in Minnesota, we don't obviously schedule our inspections, but I know that there's one local agency that's really toying around with the idea of maybe sending out kind of email notice, letting the restaurant, giving them a heads up that their inspection will take place within the next, 2 or so weeks. And so I'm interested in hearing more about that idea and how that goes. And then with consistency in that comment, we try and do joint trainings. Our team, standardizes and works on program evaluations to just continue to, work on that consistency and making sure all of us are, calling the code requirements a certain way. And then it's really interesting that COVID didn't ruin relationships, or it doesn't appear to, between operators and inspectors. I know our inspectors were, many of them were in difficult situations when they had to go out in the fields and, deal with, most of the time it was maybe angry public. So there was a lot of negative interactions. So really encouraging to hear that overall operators who took this survey didn't feel like those relationships were damaged. Now, looking at kind of the take home and summary for our employee illness behaviors, 50% of our foodborne outbreaks are due to norovirus. So how do we really address this and make sure employees are aware and management's aware of those reporting requirements? So there's definitely still employees who don't report vomiting and diarrhea to management, mainly because they don't want to lose their shift and are concerned about consequences from management. Now, the other thing is 10% of restaurants don't require employees to report symptoms and don't record employee illness in a log. I will say through my work with SNET, we're currently doing a sick worker intervention study where we're going into restaurants and half the restaurants we're providing an intervention of resources and education on employee illness requirements to see if that will change their practices. So more to come on that, but definitely need additional research and outreach there. And we also need to continue our efforts to get communication out on the need to, report symptoms, both the management training the employees and then the employees actually reporting that to the person in charge, but then also, with it being a requirement for person in charge to report patron complaints to the health department, we need to provide more education and training to, remove kind of that gap and deficiencies there. So looking at just kind of our next steps, we're going to continue to review and summarize the data. Like I said, there's a number of open-ended comments, so just trying to figure out how to best quantify those. I did share all the results with our inspectors statewide, but we do want to reach out to operators and share the results as well. This will likely be through a GovDelivery summary with some of those main findings, but we also want to include what we plan to do with the feedback they provided. So, that was what we included when we sent out the survey, is we want the feedback to better inform how we do things. So of course we want to let them know like what we're going to do with the information they provided to us. And then also just continue to disseminate the findings from the survey. I'm hoping to draft a summary and submit it for publication. And I'm also hoping to provide this summary at the NEHA AEC next summer. So of course, the goal of this survey was to take the feedback to inform future outreach and training methods and also training topics. So looking at just kind of how we had been doing things, our Gov delivery. We really want to get back to a regular schedule and frequency for providing newsletters and updates. And of course, we're going to be focusing on some of those topics that operators were interested in. So specifically, their kind of top response was wanting more information on food code requirements and food safety recalls and consumer warnings. But we also want to focus on some of those areas where operators appear to need more training and education surrounding kind of the employee illness reporting requirements, logging of and tracking of employee symptoms, and reporting those patron complaints to the health department. We also thought it would be fun to do like a Ask the Inspector column within our newsletter. So kind of like a Dear Abby, where operators could actually submit questions and we'd have one of the inspectors, provide a written response there. And then looking at, our food safety partnership, meetings, we're totally reinventing this group. We're actually going to create a charter to go forward and just pivot towards more accessible trainings and educational offerings. We want to reach out to more industry partners to get some help with this and just really prioritize and kind of try and amplify food safety messages for all of Minnesota. So this will likely mean, rather than, doing 3-hour trainings like we used to. It'll probably be more like snippets and videos that we post to the website and recordings of topics so that they can be viewed kind of whenever and are up and available to operators in industry. Presentations to industry will continue to do upon request, but those will definitely be more that virtual or recording, a lot less in person. And then inspections, our inspectors will continue to have those conversations with the operators because it definitely appears that, that's really important to the industry. And so again, I shared these results with our inspectors. So, we may brainstorm kind of some ideas on how to get maybe future updates out via inspectors and just kind of those conversations day to day out at the restaurants. And then continue to work on that consistency issue and comment that kept coming up with, standardizing inspectors and offering trainings for both local and state, so we can work through maybe issues they're seeing in the field and make sure we're calling, food code citations consistently. So just some lessons learned here. I had never created a survey that was open for the public. I've always done kind of research in the restaurant where I've recruited restaurants to participate. So this was definitely a team effort, working with, our communications office to even just figure out what picture we are going to include in the Facebook post was, a big discussion in itself. But, working with our public information officer, just stuff I had never really done before. So that was pretty cool. And then Microsoft Forms, I had never worked in that system, and it worked really well for this survey. Denise Schumacher, my colleague, is a pro, and she kind of showed me the ins and outs, and I really would do this. I would use Microsoft Forms again. It's great because it has kind of a lifetime feed of like what's happening with responses, and it's summarizing them as people are responding. So all of those screenshots of like the bar graphs and stuff on my slides that I showed you were directly what Microsoft Forms spit out. So that was cool, but you can also export your raw data and then manipulate it however you want. And I'll definitely have to do that for those open-ended comments. But when you're creating a survey, really think about your audience, things again, like saying the survey is for food workers, but calling out in parentheses, like if you work in a deli, coffee shop, bar, because we didn't want to exclude those individuals. And using plain language, also extremely important. We had to think about like not saying, are you sick or ill, but actually calling out vomiting and diarrhea specifically, especially as I mentioned, with us all being kind of foggy from COVID world and thinking about fever, sore throat as maybe sick symptoms. Open-ended comments are great. It gives you a wealth of information and feedback that you probably wouldn't get from the multiple choice, but definitely more work when it comes to quantifying those responses. And then this is just kind of a funny lesson learned, but if you expect low participation, you may be pleasantly surprised. And like I said, my goal was 150, and to get over 1,500 responses was so exciting. So. All right, and then when I presented to our inspectors, I definitely wanted to kind of call out some shout outs that operators actually gave in the open-ended responses, because I think that's really cool. So you can see here, Hennepin County, John, Bloomington Health Department, Deb Koziak, our inspector Crystal, I like her very much. Julie Eisenberg communicates, teaches, trains. Matt Finkenbeiner has been outstanding when working with me. Michelle's been very informative and patient. Peter and Crow Wing County, great and fair. Bloomington Health Department again. So just really exciting to see kind of that acknowledgement that what they're doing has been helpful to the industry. And this was a Minnesota survey, but I think a lot of these findings are definitely transferable to other states as well, especially, the information on how operators want to receive their food safety resources and info and kind of those preferred methods for distribution. And I told all our inspectors, and I'll tell all of you as well, that the work we do matters. Most of the operators really appreciate what you share with them and actually want more education and training. Sometimes those conversations that you're having with operators during an inspection is maybe the main way they receive food safety information. So definitely critical. And COVID, was difficult for everyone personally and professionally, but it does seem like the relationships between inspectors and operators are remaining positive. So that's really encouraging. So just a couple other comments for those that didn't get full shout outs or their names listed. Our local inspectors are amazing. They have guided us and helped us over the past years perfectly. They are the best. And then I appreciate the work done by health inspectors and rely on the guidance of MDH every day. I take my own responsibility as a food protection manager very seriously and appreciate support by inspectors to continually improve the process. So just a big thank you to the team that I work on and everyone else that helped. If you have, any questions, I think we have time for questions, but feel free to also email me if you want like a copy of the survey questions we asked. If you're thinking again of maybe doing something similar, any way that I can help, I would love to answer questions and share that with you.
Excellent presentation, Nicole. Thank you so much for sharing. And as you have time here over the next few minutes to read through the chat, you'll see that there's been a lot of great feedback. Everyone has really enjoyed your presentation this morning. I think surveys like this are really great for improving programs and, as you had mentioned, enhancing, improving food safety resources. Presentations or surveys like this can also be used for garnering additional support from administration or financial program support. And it, as you mentioned, it's really good for staff to get that feedback that they're doing well. So really good information. There was some comments in the chat about pertaining to the employee health policy data that it was good data to have. That knowledge doesn't necessarily indicate behavior change, right? So the knowledge of the employee health policies aren't necessarily effectuating behavior change in the presence of all the competing factors that exist. There were some questions in chat that came up during the presentation, and we do have a few minutes, so I'll go ahead and ask some of those since we've got a little bit of time, if that's okay with you. The first one was and the request for the slides in your PowerPoint. There was many requests for your presentation, and I'll just let everyone know that it is on the Breakout page, the central Breakout page, and passable under the Files tab. So those of you that would like a copy of the presentation, it's posted there in a PDF format under the Files tab. Somebody did also ask, is the survey that you guys sent out available as a resource or something that can be shared?
Yep. Yeah. So I just have it as a Word document. I had entered the actual questions and made it pretty and formatted within Forms or Microsoft Forms. So I don't know if there's a way to actually pull it from there, but I do have the Word document with all the questions we had. It just doesn't look as nice as it did in the survey, but all the content's there. So I can definitely share that as well. So no problem, because yeah, I I think, I think a lot of agencies probably are curious on, how things are going with their industry and operators. So no problem sharing. And just kind of going back to your comment on the employee illness, I think I did want to say, yeah, because most of the respondents were managers or, certified food protection managers, it was interesting to kind of see those gaps in some of that employee illness behaviors and reporting requirements. And I would imagine that, in the general restaurant worker population where maybe not everyone is manager and is trained, there's probably a lot more kind of unknowns about those requirements. So definitely probably some underreporting there.
Right, yeah. A couple of other questions that came up in the chat. Do your inspectors rotate districts, and if so, how frequently? As this would obviously play an impact or role in how some of these questions may be answered.
Yeah, so I think that really depends on agency and even with in MDH, the district offices. I can't really say with local agencies how they do it. I do know our inspectors, there has been a number of turnover over the years, so we do get new inspectors into those territories. But I don't think there's a formal process on how often they switch territories. I think it's kind of situational based and agency based, unfortunately.
Okay. And do you know the inspection report form that's used? Does it use the in, out, not applicable, not observed marking convention?
So again, that kind of varies by local and state agencies. For the state inspection reports, yeah, we use like the CFP form at the end of the report that has that in, out, not observed, not applicable. So there is always that summary on the inspection reports.
Okay, and then there was another question about, was there an option to ask if their employer was the primary source of the food safety information?
There was, in one of the choices of, in the past, I think it was in the past 12 months, how have you received food safety information? I think one of the options was from my coworkers or colleagues, and that wasn't as common as an option. I do know if it wasn't that one, it was in like, how do you receive your food safety information? And we did have that as a choice, and it wasn't a very common response. I don't have the exact number in front of me, but I can share that if someone's interested, they can message me.
Very good. All right, and so very good presentation. Any additional questions before we wrap up with Nicole's presentation? Again, a lot of really great discussion that was taking place as you were talking, really good positive feedback, and it was really well received. So thank you so much for presenting this morning.
Yeah, thanks so much for having me.
I think there are a lot of jurisdictions that are interested in replicating what you've done. So they're really interested to look at your survey and your PowerPoint in more detail. So thank you for sharing.
Great. Happy to help. Thanks so much.
All right. I'm going to turn it over to Carolyn at this point, kick us off for the next topic.
All right. Wonderful. Thank you, Becky. And thank you, Nicole. It was a fantastic first presentation to kick off our session. So we're going to transition into our next presentation. It's actually going to be a panel discussion. And so we're going to talk about standardization, right? So a regulatory food program is most effective when foodborne illness risk factors are controlled through uniform and consistent inspection procedures. So in this session, you're going to hear the perspectives of several state regulatory retail food programs that have implemented the standardization process as a component of their training program. So I'd like to introduce our panelists today. We have Rodney Blanchard. He's a food safety specialist with the Michigan Department of Agriculture and Rural Development. Rodney worked as a general sanitarian for a local health department in Michigan for 16 years before joining the state. And prior to joining MDARD, Rodney was a standardized trainer in the food program with the local health department he worked at from 2001 to 2015. He is active with CFP and is currently the Council One Vice Chair. He's been the food safety specialist in charge of the standardization of food program trainers within the 45 local health departments within MDARD. In addition to standardizations, Rodney conducts large group trainings, consultations, and the auditing of other local health departments through Michigan's accreditation program. Rodney has a Bachelor of Science in Natural Resources from the University of Michigan and is a registered environmental health sanitarian and an FDA standardized retail food safety inspection officer. We'd also like to welcome Michelle Messer. She is a planner principal with the Partnership and Workforce Development Unit in the Environmental Health Division for the Minnesota Department of Health. As standardization coordinator, her duties focus on conducting evaluations of state and local inspection staff and agency leaders to ensure they are uniform in their food safety inspection techniques and technical knowledge of the food code. While doing so, she utilizes her 23 years of experience with MDH. Her Bachelor of Science degree was awarded at St. Cloud State University. She holds a registered sanitarian credential from the Minnesota Department of Health and has been an FDA standardized food safety inspection officer since 2004. And I would also like to welcome Pamela Hendren. She is the retail food supervisor for the Kentucky Department for Public Health. Pam has a Bachelor of Science from the University of Kentucky and Eastern Kentucky University, and over 28 years of experience in environmental health, most of those years in food safety. Pam works with a team that trains and standardizes local health department inspectors on the food code. Pam also develops policy statements and regulations, assists with inquiries from the general public and industry, and assists with the Retail Food Program Standards Grant. Our panel facilitator today will be Retail Food Specialist Becky Steiner. So please give a warm welcome to all of our panelists and use your Zoom reactions to show your appreciation for them being here today to talk to us about standardization activities in their state. Welcome, y'all.
All right, so let's, before we get started going through our questions with our panelists, let's first discuss the purpose and applicability of FDA standardization, just so that we all have a clear understanding of what it is. So the main goal of FDA standardization, the main goal of the National Food Safety Program is the reduction and prevention of foodborne illness. So to that end, FDA provides several pathways towards this goal, one of which is the standardization of retail food safety inspection personnel. Standardization is the process where regulatory personnel can demonstrate their knowledge, skills, and proficiency of the FDA food code and its provisions through a uniform system of measurement. The procedure has its focus on the foodborne illness risk factors, food code interventions, and the application of HACCP principles, and it's centered on a risk-based inspection approach. So the purpose of FDA standardization is to promote uniformity and consistency of regulatory retail food inspections. It's used to reduce the risk of foodborne illness based on science-based interpretation of the food code and effective principles to achieve compliance. The standardization procedure is not intended to provide a basic training, but rather it's intended to confirm a high level of knowledge, understanding, and application of food safety principles. Standardization evaluates the candidate's understanding and application of the food code provisions and inspection technique. So during the standardization process, the standard imparts knowledge during the exercise to assist the candidate with becoming more proficient in interpreting and applying the food code and risk-based inspection techniques. There are opportunities during the exercise for teaching moments that clarify new interpretations or to point out examples during the standardization exercise. This process will ensure that the candidate recognizes foodborne illness risk factors, food code interventions, and good retail practices. It confirms the candidate can achieve practical and immediate correction for out-of-compliance risk factors, and also that they can effectively communicate with establishment personnel to understand and assess processes and principles and to gain short-term and long-term corrective action. So as a result, the standardization process can strengthen active managerial control at the retail level to ensure better compliance from industry. Therefore, it encourages widespread uniform application and interpretation of the FDA food code and enhances local regulatory environment for retail food operators. Standardization is a tool for measuring technical proficiency and provides a solid foundation for a uniform regulatory retail food program. In terms of applicability, FDA standardization also supports jurisdictions in obtaining and maintaining a trained regulatory staff. The standardization procedures manual is intended to serve as a template for state and local regulatory jurisdictions to develop their own written protocol to ensure personnel are trained to competently conduct inspections. The standardization procedure is applicable to retail food programs as part of the retail program standards, specifically as part of Standard 2, which is trained regulatory staff. Standard 2 applies to the elements of the training program for regulatory staff and outlines steps for achieving a required level of inspector competency. So with that background info, let's go ahead and ask our panelists some questions and see how things are working in their specific state. So our first question is, how is your state set up with regulatory retail food inspection work between the state and the local health department? So Pamela, I'm going to come to you first on this one, on this question. How does the standardization process work in Kentucky?
Sure. In Kentucky, it is written in statute for local health departments to work as agents of our cabinet or Department for Public Health.
Okay. And Michelle, how about in Minnesota?
As Nicole stated in her previous presentation, the Minnesota Department of Health has direct authority over about half of the state geographically. We delegate authority to 28 units of government, which is a mix of cities, counties, and multi-county community health boards.
Okay, so for Minnesota and Kentucky, it's more like a delegated authority.
Mm-hmm.
How about in Michigan, Rodney? How does it work in Michigan?
Well, in Michigan, we have been a home rule state since 1909. So our Constitution gives cities and villages the ability to pass laws and ordinances related to their municipal concerns, but they are still subject to the Constitution and general laws of the state. So statewide, we have a single food law that all jurisdictions are subject to. That state law prescribes powers and duties to the Michigan Department of Agriculture and Rural Development, or MDARD, and delegates in the law the authority to inspect food service establishments to the 45 local and district health departments. It does require, though, that MDARD provide training, consultation, and perform periodic evaluations of each of those food programs. And to perform those periodic evaluations, an accreditation process was developed starting back in 2000, where each local health department is assessed in 10 essential statewide programs, including their food program, every 3 years.
Okay, so more of like a home rule type operation or setup in Michigan. Is standardization of local health department employees required under your delegation agreement between the state and local health departments, or is it voluntary? And if it's voluntary, how do you engage the local health departments to participate in the standardization process? Michelle, I'll go to you first on this one.
The standardization process in Minnesota is voluntary under our delegation agreement. And many of our local agencies have signed up for the program standards, so they want to meet standards 2 and 4, which is standardization within 18 months of hire, but has now been changed to 24 months of hire.
Okay. And standard 4 is quality assurance for those who, we talked about standard 2 being trained regulatory staff, and standard 4 is quality assurance. For those who don't know. Pamela, in Kentucky, it's voluntary under the delegation agreement.
Yes, that's correct. In Kentucky, it is voluntary. Currently, there's approximately 43% of local health departments in Kentucky that are standardized. Each one of the retail food technical consultants in Kentucky emailed their local health departments in their area of the state to solicit standardization this past year. That's one way we're encouraging participants. We have a Kentucky Food Safety Seminar that's coming up in October of this year. And our FDA retail food specialist, which is Becky Steiner, she's going to present on the importance of standardization at the seminar. And we're hopeful this will encourage more local health departments to get standardized also.
Okay. How has, in your state, how has the standardization process helped to achieve a higher level of competency with inspectors? What have you seen, Rodney, in Michigan?
Well, and I kind of wanted to respond a little bit to that last question as well. While standardization
My
itself is
apologies.
not
Go back. Well, I'll go back to that slide. Go ahead,
standardization
Rodney.
in Michigan is not mandatory, but the way we achieve it is through training that is required as part of minimum program requirements in our accreditation program. So MDARD and the local health departments have agreed on minimum program requirements, which include that all new inspectors to the food programs in Michigan will be trained by a standardized trainer. So the training that's required is consistent with the training required to meet standard 2 of the voluntary national retail food regulatory program standards. So as such, we've been able to basically get each local health department to have anywhere between 1 and 8 standardized trainers that are standardized by our 4 MDARD standardized trainers that are standardized by the FDA. So when you think about the multiplier effect that's happening, is pretty impressive. Our FDA retail food specialist, John Tran, shout out to John, standardizes 4 MDARD employees who standardize around 75 standardized trainers of the local health departments and within our department, who then train and provide the QA on hundreds of inspectors here in Michigan. So it has ended up being a pretty effective way to do it.
Yeah, thank you, Rodney, for making me go back to that to explain that, because that's exactly the intent of what we want to happen with standardization. We want that multiplier effect to occur, and that does kind of lead me into the next question when it comes to training. Actually, I think I might have the questions out of order on here. Let me go back here. Oh, I'm missing a question. I'm missing a question on the slides, but how do you weave the standardization elements, such as training and field standardization, into the quality assurance work that you do with your local health departments? And for those of you who are looking at the presentation slide, you don't see that question up here on the slide. But Rodney, you were kind of alluding to this a little bit in the last thing that you just answered.
Yeah, and as part of the accreditation, MDARD assesses the training of all new staff and then completes quality assurance evaluations of the local health department staff in the field while they conduct regulatory food inspections. And the rubric used to score the field is kind of a field evaluation worksheet, which is geared toward risk-based inspection methodology. And then another one of our minimum program requirements for accreditation is that each new inspector to the food program in Michigan must attend an MDARD food law and Michigan modified FDA food code course, which is a 2-day training on the Michigan food law, the FDA food code, risk-based inspection methodology, and how to assess active managerial control. And that course is instructed by myself and my 3 coworkers in the local health services unit, who are the standardized trainers here in Michigan. Our local health service team also teaches large voluntary group trainings on plan review, accreditation, and specialized processing each year. So.
Thank you. And thank you, John Tran, put the question that we're discussing into the chat. I appreciate that, John. Michelle, do you want to explain to us how you weave the standardization elements such as training and field standardization into the quality assurance work that you do with the locals in Minnesota?
Sure. I'm on a team called the Partnership and Workforce Development Unit, which Nicole is on. Shout out to Nicole. And as part of the team, we provide what we call a new employee or cord food training and risk-based inspection training twice a year to state and local new employees. In that training, we cover the 20 bullet points under what a quality assurance program shall assure for each inspector. And you can look at that sometime. And some of these things on that 20-point list are code interpretations, inspection equipment, corrective action for long-term compliance, and many other things. New staff hear about standardization from the start of their employment and in core training, so they get familiar with the process and what standardization is. Minnesota Health and Minnesota Ag work together to hold standardization in service annually for all this local and state SFSIO standards. The past 2 years, unfortunately, it has been virtual, but with that virtual, we've had much better attendance because people don't have to travel to a central place to have this training. We do a survey each year prior to developing the in-service agenda, asking those group of standards what questions they have or what do they want clarification on. The agenda covers food code clarifications. We do a local agency roundtable check-in to see how agencies are doing, if they're having any issues. We do, as standards, keep a list on Excel spreadsheet. What are the most swings and misses we're seeing with each of our standards? And this year we had what's been a favorite is it a TCS food or not? And we use the poll feature on Teams to ask the standards if certain foods were TCS or not. MDH also has what we call Regulators Forum quarterly. We used to call it Regulators Breakfast, but we didn't serve breakfast. It was just always in the morning. So we kind of are rearranging it and readapting it. So it's called the Regulators Forum. It's a statewide meeting attended by MDH and our delegated agency food inspection staff. The meeting contributes to statewide uniformity and consistency among the regulators and management in the interpretations of statutes and rules and procedures. We do a lot of food code interpretations, announcements. We share updates within our state for if we're doing any new rules. And standardization questions are regularly discussed in these meetings. Participants at both the in-service and the Regulators Forum receive CEUs to help with their RS and their standardization.
Excellent. So now let's get to the question that we see on the screen. I apologize, I didn't have the slide for that last question. But how has standardization helped to achieve a higher level of competency with inspectors? Let's go to Pamela for this one. Let's talk about this one for Kentucky.
Sure. In Kentucky, our RS, registered sanitarian training is more stringent actually than this training requirements for standardization. It's 10 CEUs per year is what's required. We also host the Kentucky food safety seminar annually, and it's open, that training is open to all local health department inspectors.
Okay. What about Rodney in Michigan? What have you seen here?
Well, I think a great anecdotal evidence of the increase in competency with inspectors is that prior to 2000, there was not any real consistency within Michigan on how a new inspector to food programs of the local health departments were trained. The training programs were varied. And as such, if an inspector wanted or needed to move and apply for a job in another jurisdiction, there was just no confidence back then that the inspector had been trained competently. But by having all the new inspectors attend the same initial food law, food code training, and then having them all be trained by a standardized trainer to agreed upon minimum program standards, we really have achieved a point in Michigan where there's a high level of confidence in the competency of anyone who has completed that training process with any of the local health departments. So this has been a huge benefit to the local health departments and our department in being able to hire staff trained in other jurisdictions. And I do want to make mention that accreditation field process of assessing the field inspectors doing inspections, we think has been a key to increasing the quality of those risk-based inspections.
Excellent. That's a great point. Michelle?
The exercise just gives the inspector, I think, more confidence, and we kind of give them tools doing the risk control plans during standardization and the food process flows, which are really beneficial if they need to do a foodborne illness outbreak. They can trace the steps where the food was. And even though it's not a training, and we always stress it's not a training, anytime I've ever gone out with anybody, and my colleague Jim will say the same thing, everybody always says, wow, I learned a lot. And I also, as a standard, every time I go out, I learn something new. So it doesn't matter if you've been an inspector for 2 years or 20 years. You learn something new every time we go out.
I would agree. I would say that's definitely true. There's always new things on the horizon. What do you think are the benefits? What have you seen to be the benefits to the retail food industry of having inspectors, standardized inspectors, food safety inspectors doing the inspections of retail food establishments? Pamela, what would you say?
Definitely it promotes uniform and accurate inspections, and it also reduces and prevents foodborne illness.
Yes, that's definitely the purpose and intent of it. Michelle, do you have any additional?
Sure. We always hear from industry that they want everybody to be on the same page, calling violations the same throughout the state. And as you can see from Nicole's presentation, it's really important to have, the industry wants us to have consistency between inspection staff all through the agencies, state and nationwide.
Yeah, that's a big one. Uniformity and consistency, especially when there are multiple variations of food codes that are adopted across jurisdictions. That's something that industry can definitely have frustration with, is inconsistency and lack of uniformity in how their inspections are conducted. Anything additional that you would have here, Rodney?
Yeah, I think a couple of things that we've tried to do in Michigan to help improve consistency with industry is just some of the communication practices. For one, we each year have except for COVID, we have a 2-day conference with all the standardized trainers where we get them all together and talk about consistency within the state. That's actually coming up next month, and we have 73 people attending. I think all but 3 standardized trainers, and it's voluntary, but all but 3 of the standardized trainers in the state are coming. So we also have an email group where the standardized trainers are all able to and encouraged to discuss any issues of consistency that they have. So it's a closed group just to the standardized trainers, and it really enables them to talk about consistency between, especially important for the regional and national chains. So if somebody sees something happening at a chain location in their county, they can talk and see if that's a statewide issue or if it's just something they saw in their county. It also allows us to immediately communicate to the 45 local health departments when industry provides us with information. So we have a lot of our industry partners that will send us updates on product or menu, et cetera, and we can instantly forward that information to all of our local health departments, but get it into the right hands, actually get it into the hands of the standardized trainer at each of those local health departments to disseminate that information. So we really feel that some of these communication things we put into place have been very helpful in ensuring consistency with our industry partners.
Good, yeah, and looks like Rebecca Long put into the chat that email group for standardized trainers in Michigan is very helpful. Maybe something that others can think about taking in and possibly implementing or adopting something similar in their jurisdiction.
And actually, I should probably add, we have a similar email group for all the plan reviewers in our state. Again, closed group just to all the plan reviewers. And then we have yet another email group for specialized processing. So most of our local health departments have had at least one person take FD 312, the FDA course on specialized processing. And everyone who's passed that course is kind of in that email group. So again, as specialized processing comes up around the state, it helps shores up our consistency in addressing that statewide.
Very good, very good. We will open it up at this point to any questions from the audience. If anyone, I've seen a couple, I think, come through chat. One person is asking, how does the state get individuals qualified for standardization? And I'm not sure if this question is asking about a state food safety inspection officer being qualified for FDA standardization. That is something that you'll want to reach out to your FDA food specialist about, to have a conversation with them. And if somebody, one of my colleagues can put the link for the retail food specialist link in the chat, might be helpful. But there's a nomination process that's outlined in the standardization procedures manual that talks about this, how to be eligible for standardization. And then I guess we could ask for each of the panelists how it might work within your individual state. Thank you, John. There's your retail food specialist directory.
I can speak for Minnesota. We follow the standard 2 model. They have to take all the FDA ORAU courses, have to take our food code training courses. That's just what I'm talking for, is just mainly for staff, not the SFSIO standards. They also have to do all that.
Okay.
Yeah, in Michigan, anyone we standardize, basically we've copied that exact template from FDA of what the requirements are for us to be standardized. We do limit who we will standardize to employees of the 45 local health jurisdictions or our own MDART employees. We have had, private consultants, et cetera, reach out to us in Michigan and see if they could be standardized by us. And that's not something we've done yet. We've limited it to who are delegated authority under our law. So.
In
Okay.
Kentucky, it's similar. We only standardize local health department inspectors who conduct those food service inspections. In Kentucky, if you wish to be standardized, you would just reach out to your assigned technical consultant, and they'll email you the nomination form to fill out. And we ask that they have at least 1 year of experience conducting food service inspections, and then we'll just move forward from there.
Okay. And there's another question. It looks like in chat, Kentucky's standardization process is very similar to what was described by Michigan. Is there anything on the horizon for Kentucky to require standardization?
We're not looking at it as a requirement. We are talking about quality assurance, and that's still under development in Kentucky. We do plan to weave quality assurance into the standardization process, but that's still all being developed right now.
Okay. Any additional questions from the audience? Well, you may think of a couple more. We do have a couple more items that we can go through here. The first one, Michelle, I'll direct this to you. Have you in Minnesota been able to quantifiably measure any impact of having standardized inspectors?
Sure. In Minnesota, as kind of Nicole alluded to, we love to do surveys apparently. So we did a survey this year of our delegated agencies, and we asked the question, we asked about the importance of standardization, and 75% said it was extremely and very important to provide standardization. Here's the slide that Becky just put up. One of the comments from a local agency was the training and standardization make a true difference in consistency among inspectors and provides a risk-based inspection foundation for the regulatory community. So you can see we had the choices of extremely important, very important, somewhat important, and not important at all. And we were so happy to hear that standardization is really taken seriously and they really do like it. And then this slide shows our goal was to have 50% of the statewide of Minnesota standardized. As you can see, in July of 2017, we started at 34%. It has steadily gone up. Of course, 2020 with COVID, we weren't doing inspections. We were busy doing COVID things. So our last was July 2022, and we're up to 81% of all staff in Minnesota are standardized. So we surpassed our goal of 50. So we're excited about that.
That's really great that you are able to, that you have this data, that you're able to measure the impact of the work that you're doing with standardization and show that it's making a difference in your agency and with your staff. So thank you for sharing that.
Thanks.
That's really good information. I'm sorry, were you about to say something? I feel like I might have cut you off. Okay,
No.
good. Okay, Donna Walker is asking, has anyone had experience with counties or states that use a point system regarding hurdles that you have encountered during standardization? I'm not sure if that was directed at the panelists or if that was directed more towards just anyone in the group in the chat.
I should have said
and thank you.
I should have said, Becky, and Kim, my supervisor, put in there. Yeah, this was from a huge FDA and NEHA cooperative grant that we've been able to do the standardization. I'm the standardization coordinator, and that funds a lot of my positions. So having that money available and having one person kind of coordinate things has really, really made the difference in Minnesota. So I would advise everybody to take advantage of those grants out there.
Excellent. Yes, thank you for pointing that out. We've got one final question here. What do you think are the benefits to the public, to consumers, of having standardized food safety inspection officers? Rodney, what would you say?
Well, as one of the other panelists said earlier, everything we do, and in our case through standardization, training, accreditation, is to minimize foodborne illness in Michigan. So obviously the public benefits from all of those programs. in the fact that the more consistent we are in implementing food safety, then we're going to help to minimize foodborne illness. But also, especially with social media, I think, the public ends up talking to each other a lot about food safety in Michigan. In some cases, they take out temporary license for events, but they certainly compare notes with family and friends around the state. And the more consistent that we can be within the regulatory community in how we do inspections, the quality of our inspections, it just gives our profession credibility, and it gives confidence to the consuming public who, hey, pay our salaries. So I think when they find out they're being treated similarly, regardless of where they are in the state, it really does give us that credibility. So.
It's 10 minus 10. Is it 0 or 10?
And then I've got another question that that came up. What has been the feedback from staff that regarding the standardization process? So any feedback that you've gotten from your internal staff regarding having gone through the standardization process, what have they communicated back, either positively, or what have they shared have been their biggest challenges with it? Let's start with maybe Pamela.
It's all been positive with our staff there at the state that have been standardized by the FDA. We have 3 people standardized currently. One just newly became standardized in March, and the other 2 have been standardized for several years now and have been re-standardized, but it's all been positive for them. And then in turn, when they go out and work with people out in the field, standardizing the local health department inspectors, they enjoy working one-on-one with those local health department inspectors and standardizing them in the field also. So it's all been positive in Kentucky.
Very good, yeah. And that's good to foster those relationships too between the jurisdictions for the ongoing work and training and development. So that's good. Michelle or Rodney, do you have anything additional for that? Any feedback from staff regarding the standardization process?
They all seem to like it, and like I said before, I think they've learned something every time they go out there. The big negative we hear is that having to be re-standardized every 3 years. It just seems like in a flash, it's been 3 years, and it's time to do it again. Having the 6 or the 4 inspections, it's the time-consuming part of it. That's kind of the negatives that we hear.
So overall, the feedback in Michigan has always been very positive. I think you can point to the fact that we're going to have over 70 people show up in the middle of the woods of northern Michigan next month voluntarily. All the standardized trainers are coming, means that they think it's a pretty positive experience. One thing we've done to address what Michelle just said was we've moved to a model where every year we go out and do maintenance inspections with all the standardized trainers. So we do a 2 a year with every standardized trainer instead of waiting the 3 years to do the 6, because we found the same thing, that doing 6 at one time was cumbersome, just emotionally, mentally, it's tiring. But by going out every year, that way we get to have one-on-one contact every year with all of our standardized trainers, have a chance to work with them. We found that to be very productive. We also, another step we took was to say that all of the standardized inspections could be actual regulatory inspections, so that we're not asking them to just go out and do an exercise. All of the inspections they do can actually count as regulatory inspections. So that really doesn't add much extra time into their work schedule, because we're basically just tagging along with them on a couple of their regulatory inspections. So that, I think those 2 steps have been very helpful in especially selling it to the health officers and EH directors, that this won't be an added burden to their departments. So
Minnesota does the same. They can be routine regulatory inspection, which really has helped as well.
That's a good point, and thank you for sharing. And we're getting some good feedback in chat too about, looks like from some locals that are sharing they appreciate the experiences working with their standards. It's a good opportunity, a learning opportunity, and so some good comments in chat about that. How do you see the standardization process evolving, or what would you change, if anything, when it comes to the standardization process? And feel free, anyone.
In Kentucky, it had been suggested, of course, this would have to come from the FDA, maybe for re-standardization every 5 years instead of every 3 years, might make it easier on our local health departments, especially the ones that are those single person working in a health department. They do all the programs. They do on-site swimming pools, rabies, COVID. They do it all. So it might make it easier on some of those smaller local health departments.
I agree.
Agreed. In Minnesota, we have 28 local health agencies, and there are only 4 of them that do not have a standard, and that's for reasons somebody may have left. Some of them are one-person agencies, and like Pam just said, they've got so many competing priorities that, you know, to take the time out to be standardized is really burdensome to them.
I'd say in Michigan, I think the overall process is working pretty well. The one thing I think we're trying to incorporate into it is just when you look at the scoring sheet, the standardization inspection report, it's really focused on food code knowledge, food code. We're really trying to, through the accreditation process, and as we work with our standardized trainers, you know, weave more of the risk-based inspection methodology and conversations about active managerial control into it, which I know is part of the standardization process, of course, but it's not really part of the graded part of it that much. So, you know, we're just really trying to have that be as much of a focus or more of a focus, really working with our standards on risk-based inspection methodology and the assessment of food safety management systems.
See some agreement with you all there with that 5-year renewal instead of 3, possibly less inspections. Yeah, it does come down to workload, and as you mentioned, Pamela and Michelle, the locals are often tasked with doing more than just food inspections. They're managing and multiple program areas, food pools, hotel, childcare, on-site, vector control, lodging, etc. So yeah, food is very often a portion of their multiple work duties. So something to definitely consider. Maybe another question for the group. Did standardization help identify gaps that informed additional training needs? And I think we kind of touched on this a little bit, but informed training needs or other department activities such as monthly calls to discuss interpretations. I know we kind of, Rodney talked about this a little bit, but.
In our regulators forum, we have a lot of our agenda fodder comes from standardization, what we've seen in the field, new processes. And that's, I think, has really helped train our inspectors as well. And we have our local partners present in there too. It's not just state, Minnesota Health and Ag presenting these topics. So that's helped engage, I think, our local agencies and their staff as well.
And is this feedback communicated via inspection results, or is this just solicited?
It's solicited from what we've seen in the field and some questions that we are getting from our standards.
Yeah, I agree. In Michigan, I think a lot of what we think about in terms of gaps or changing training slightly comes from our work with our standardized trainers, what we see in the field, what we see them asking questions about or talking about on that peer group, that email group that they have. Those both certainly help direct us in our future training endeavors.
I agree with Rodney and Michelle. In Kentucky, definitely, when we have our retail food specialists out there working in the field with the local health department inspectors, it helps ID some processes that are going on in the field that we wouldn't have known about otherwise, and we can discuss and talk about how to move forward with those processes.
I believe each of your jurisdictions are enrolled in the program standards. I know Kentucky is. If so, how has your work, if any, done around Standard 2 helped with the development of your standardization program?
Well, as I mentioned earlier, as we have talked about our accreditation process and our minimum training requirements for new inspectors in Michigan, we've always tried to make that align with Standard 2, so that anyone who did want to become enrolled in the voluntary standards through the work that was already being done through standardization, accreditation, and the training we were already doing, they would meet that.
I agree with what Rodney said.
Oh.
A lot of our jurisdictions have signed up for the program standards and want to meet Standard 2, and they've also found a lot of value with standardization. So we do get high participation with standardization and wanting to be standardized.
Very good. All right, well, I think we're at the end of our questions. I really appreciate you all for participating today. Thank you so much for sharing what is happening in your jurisdictions, in your states, and the great work that you're doing with standardization. I hope that everyone has enjoyed this session, and I will turn it over to, I guess, Carolyn.
All right, that was a fantastic panel discussion. Really great questions from the audience, and really good to hear what things are happening in some of our states in our region. So we are scheduled for a break right now. We are running just about 10 minutes ahead of schedule. So we were scheduled for a 15-minute break in order to ensure our next set of presenters do have time to set up and get ready to go. We are going to take a break until 11:35 Eastern, 10:35 Central. So get that next cup of coffee, run around the office, print that memo, whatever you need to do, pet the cats, feed the kids, all of those good things. And we will see you back here at 11:35 Eastern, 10:35 Central. All right, enjoy your break.
And hope you all had a chance to get a little bit extended break from what we had on the agenda. I refilled my coffee and I pet my puppies and enjoyed my little extra time. So hope you all were able to do something similar with a few extra minutes. So welcome back. Our next presentation is about the development and implementation of a statewide food complaint system in Kentucky. And the goal of this presentation is to discuss the development of Kentucky's online food complaint system that was designed to provide surveillance for foodborne illnesses and to improve the efficiency of workflows. So it will include challenges that were encountered during the development and also share some specific instances when the data collected led to public health action. There will also be a time-lapse system demonstration that will be provided. So our speakers for this session are Nate Wilson and Brooke Spillman. Nate is the Quality Assurance Program Manager and the previous Rapid Response Team Coordinator and Epidemiologist with Kentucky Department for Public Health Division of Public Health Protection and Safety. Nate worked in the food safety branch starting in 2021, and prior to this role, Nate worked in the Division of Epidemiology and Health Planning at Kentucky Department for Public Health. He holds a Master of Public Health, a Bachelor of Public Health, and is a PhD candidate at the University of Kentucky. Nate is also a registered sanitarian in the state of Kentucky. Brooke Spillman is the Rapid Response Team Coordinator and Environmental Health Program Administrator with the Kentucky Department for Public Health Division of Public Health Protection and Safety. She started her role in June of 2022. Previously, she worked as the COVID variant and cluster epidemiologist in the Division of Epidemiology and Health Planning at the Kentucky Department for Public Health. Brooke holds a Master of Public Health with a concentration in Preventative Medicine and Environmental Health, a Bachelor of Public Health, and a Health Communication Certificate from the University of Kentucky. Welcome, Nate and Brooke, and I will turn it over to you.
Thank you so much for the great introduction, Becky. So we'll get started here. And thank everyone for joining this central session here and for listening into our presentation. We're going to be discussing the development and implementation of our system and kind of why it's important and why other jurisdictions should adopt similar systems. So I'll move on to the next slide. So this slide is just going to give us a little bit of an overview of what we'll talk about here today in our session. We're going to go into some of the background of why we wanted to go into this system, why we adopted this, kind of what led to us building this up here. We'll talk about why it's important to have one, what's the purpose of a system like this, as well as what's included in it. So all the different features that you'll see when we go through the demonstration and kind of how those work together and how it really makes a really cohesive system and a really great opportunity for surveillance in Kentucky. We'll also talk about some of the very specific things, such as generating an alert and what that entails and how that kind of works, kind of our alert system that's built into the system. We'll talk about the benefits of having a food complaint system. There are quite a few, so we'll go through those pretty quickly. And then we'll also mention in particular the timeliness for interventions and how this can really improve your response time to outbreaks or other kind of issues, food safety issues in your jurisdiction. And then lastly, we'll talk about some of the strategies that we've come up with for branding the system and marketing the system, making sure that we can get it out there and get the word out there, as well as our timeline for implementing this. And we'll probably have time at the end for a demonstration as well, to kind of show some of the actual details of the system and give you a picture for that as well. So here's the background for why Kentucky started looking into a food complaint system. In 2019, the Virginia Department for Health presented their version of a food complaint system. I think probably a lot of us have heard about this. It's a pretty famous one. They call it My Meal Detective. And they've had that around for a few years now. And they presented this, I think it was at the National Environmental Health Association. I presented a very similar presentation to this at NEHA as well this year. So if you were at that presentation, you'll be seeing some similar slides here. So some staff from the food safety branch in Kentucky were attending NEHA and they saw this presentation that Virginia put on. And they really saw an opportunity for growing this program and building something in Kentucky that was very similar to that, to really improve retail food programs as well as manufactured food programs. So then from there in 2021, I moved into food safety branch. This idea was floating around to have a food complaint system, and I had some background in red cap projects already. So we decided to begin pursuing this project, and that's kind of how we started this off and started this process here. And I'm going to turn it over to Brooke.
Alrighty, can everyone hear me good? Thank you. So the goal of our complaint system is to identify food complaint patterns and in turn identify outbreaks sooner. So if you have any experience identifying those, you know that it can take quite some time between the patient eating, becoming ill, and then reporting that. So with this system, we want those complaints to come to us directly before they have to go through the interview system, so we can identify those patterns before it becomes a much larger outbreak and take care of it before then. And not every complaint will warrant a follow-up. That's because we all know how surveys can be. Some people will maybe just vent their frustration. So we're not going to send our people out to look into those, but we're really looking for those patterns. We will encourage our local health department to follow up with every complaint, but it can be a daunting task, particularly for densely populated counties with not quite enough staff to be able to go out and do that for every single complaint. But like I said earlier, what we're really interested in are those patterns. So say that 3 people that aren't in the same household, they don't work together, anything like that, they put in a complaint for a specific place and they're all kind of similar. You can easily identify a pattern there, and we'll reach out to our local health departments, discuss this, and see what our next steps are. So next slide, please.
And just to add to what Brooke said there too, when not every complaint is going to warrant a follow-up as well. We also know that last meal bias is a big problem with a lot of these food complaints, and someone who just ate somewhere recently is going to think that the very last thing that they ate is what caused their illness. But with foodborne diseases, we know a lot of times it can take, the incubation period can be a much longer time than that, up to 5 to 7 days for some of them. Yeah.
And I know I believed that as well before I had some experience in epi. If I ate something and became sick a couple hours later, it was that something. But as I learned more over in epi, I was able to realize that it's not always what you just ate. It could take up to 10 days for some illnesses to impact your health and, you know, get all those nasty symptoms. So what is included with our system here? Whenever you open up the survey, which Nate will go through later, it includes a comprehensive food history. So I think it goes up to 3 to 5 days before you started feeling ill, because like we mentioned, it might not be the last thing that you ate. We need to know what other things you ate to see what exactly went wrong and where the illness came from. There will be sections that focus on retail food complaints and manufactured food complaints. So a retail food complaint would be like at a McDonald's, or a manufactured food complaint would be like a prepackaged product that you bought from Walmart and took home yourself. And if that patient did end up getting sick and went to their doctor and a specimen was collected, have the results to that, we have an area for them to let us know what came of that, so that we can look in our NED system and confirm that, and, you know, have laboratory results to back up this complaint. Then we want them to describe their symptoms as well, because if they don't have that laboratory result, symptoms can also be specific to each different illness. So we want to know maybe if they're vomiting or having a tummy ache, it might be one illness, but if they're having, you know, sorry for the descriptors here, but if they have bloody diarrhea, it may be something else. You know, we need to know those things to narrow it down. And then there's also an option for the person submitting the complaint to either go through and submit it on their own, or if they don't have the capacity to be able to do that on their phone or a computer, they can choose to have their local health department reach out to them and have them go through it with them and fill out everything, ask them the pertinent questions. And I mentioned earlier, we have sections for retail and manufactured food, but we don't want everyone to have to go through all of these different questions that don't matter particularly to their own complaint. So we built in some branching logic into our REDCap system. So if you identify McDonald's, we're not going to ask you a bunch of manufactured food questions. And then there's some other branching in there. Nate, if you want to help me out with that, I know there's a lot in there.
Yeah, I mean, we go into different things like did you get lab results tested or anything like that? And if you were, what was the result from the lab results? If they never went to see the doctor, we're not going to ask them those questions if they ever got tested, that kind of thing. We ask them if they had symptoms. If they say no, they didn't have symptoms, we're not going to ask them a bunch of symptom questions. And there's other things built into that as well. I know for the comprehensive food history, we're really only interested in collecting the food history if they say that they have a reportable disease, one of our Kentucky reportable diseases, like Salmonella, E. coli, Listeria, those kinds of things. That's when we're really going to get into the food history, because that's when we know that they're going to be something we have to investigate further, most likely.
And we've all taken a survey, and sometimes they can be super lengthy. We do not want someone to get halfway through and think, man, this is taking way too much time. I'm done with this. I'm not going to submit it. So we want to make it as short as possible, so we do get those complaints come through and we can look at them. And we also have built into our RedCap system automated alerts and reports. So if someone submits a complaint, the local department of their station is automatically alerted. And we also have it set up that we can pull region-specific reports to let the epidemiologist in that area know. So if it's just happening in one county or if it's happening in a region, we want to be able to communicate that to everyone involved, so it just doesn't get siloed into one area and maybe two counties aren't communicating and there's an issue going on, but there's only two over here. There's only two over here, so it's not that big of a deal. But when you realize there's four or more, it starts to become a big deal. All right, passing it back to Nate, I believe.
All right, I'm going to go into a little bit more detail about generating an alert and kind of what that entails here. Make sure I'm not muted. I guess I'm not. Okay. So one thing that we did to begin with, to really make this really simple for our health departments that are going to receive these alerts, is we created a guidance document that helps them understand exactly what to do when they receive an alert, what to do when they receive an email about something. How do they need to respond to these complaints that are coming into their health departments? We created this recommendation document, and we wanted to make sure we highlighted that it wasn't a requirement that they follow up in this specific way, but it's our recommendation that they follow up in this way. Because of the way Kentucky is structured, our retail program actually sits at the local health department level. So they're the ones that go in and they regulate, and they give the inspections and all that kind of thing. So the jurisdiction, or the power of jurisdiction there, sits with the local health departments. And so we're providing the recommendations for how we would respond to these complaints, but they're recommendations, not requirements. That's a pretty comprehensive guidance document that goes into like each different type of complaint that could come in, how it's going to appear when they receive it, and all the steps they should take, as well as resources that they can look into, such as our outbreak support manual and other kind of foodborne outbreak responses that they can use to really inform their program. So what happens is when someone actually leaves a complaint, they click the submit button on the RedCap form. That's going to generate an alert for a specific county's health department. And that location where it's going to generate for is depending on the establishment that they're implicating in their complaint itself. So if they say that they ate somewhere in Fayette County, and that's where they think they got sick from, then Fayette County is going to be the one that receives that alert for that complaint. If they say they ate in Franklin County, for example, Franklin County will receive that alert. The other thing we can do with this that we haven't set up yet, but we're planning on setting up, is setting up epidemiology regional specific alerts as well. And so we have regional EPIs across the state who respond to different counties, and that one is actually going to be specific to the patient's county that they're reporting from. So if someone ate in Anderson County, but they live in Franklin County, we want to make sure that Anderson County Health Department gets the alert for the establishment, but that Franklin County's epidemiologist gets the alert for Franklin County. So we can set up alerts to do multiple different things here in different ways so that everyone is involved and everyone's really included and brought to the table when we have these response issues. The other thing that we can do, and we already have set up for this, is local health departments can request a line list for all complaints that they've ever received from the beginning of time, basically. And what that does is it really helps them look at, okay, here's the new complaints, here's the patterns that we're seeing across those, and compare them side by side, as opposed to having to look at separate emails to look for those. When an alert is generated, the local health department is going to receive a single email that has just the main details from the complaint. It's not going to have all the variables in it. I think the food complaint system has somewhere around like 200, 300 variables total. And we don't want to send 200 or 300 variables in a single email every single time someone leaves a complaint in the system. So we pulled out what we thought were the most important pieces for that they need to respond to. And that's what's really shared with them in that kind of brief email that's reported to them. But they can request that full line list, which is going to be helpful to them if they ever need to do any kind of studies, or they want to look into what's the most common type of complaint, what's the most common type of food, etc. And then we can also have specific reports that can be generated for health departments that can help them identify anything else specifically. So if they're only interested in a certain restaurant, we can pull reports that have just that restaurant has been mentioned in this report. And that can be almost like a really helpful tool when we know that there's an outbreak occurring in a certain establishment, and they want to look at, okay, how many complaints do we have total from that establishment? So we can do those specific things on a case-by-case basis, depending on what the needs are and what kind of patterns have been identified previously, or what is known about the outbreak ahead of time. All right, I'm going to turn it over to Brooke for the next slide.
There we go. I was muted.
And
So-
and we'll answer questions at the end, I think, if someone's watching the chat.
So the
Yes,
reason we wanted to
we will address the questions at the end. Sorry, Brooke, we'll address all questions at the end.
You're fine. I'm just gung ho to talk about this. I love it. So the reason we started developing this is because we really saw the benefits in it. There's, instead of a patient calling their local health department and just leaving a complaint there, we're going to have a centralized system where we can review all of those complaints, and we can use that for data comparisons to be made across counties and jurisdictions, and that will help us with informed decision making. So we don't want to blindly go out and just look at all of these complaints that someone may have. We want to see the data, and we want to know that what we're doing matters. So this also supports multiple programs at the state and local levels. They're specifically for the state, I'm the Rapid Response Team Coordinator. This improves the timeliness for our outbreak response and helps us address problems faster. That's the whole point of Rapid Response Team. It's got the word rapid in there. We want to be able to do it quickly. And at the bottom here, we mentioned the retail program standards set by the FDA. It will help our local health departments and jurisdictions meet that requirement for that grant as well. And another benefit of this is that our local health departments or jurisdictions have dedicated a specific staff or multiple staff members to support the monitoring of these complaints, and they will assist with the surveillance. So it's not going to be all put on us or all put on them. It's really going to be a joint effort between local health departments and the state health department. Next slide, please. So this page really talks about the benefits of having this system in REDCap. Like I mentioned earlier, a faster response time to food safety issues. We really want to get ahead of these before they become a massive outbreak. We want to protect Kentuckians and make sure that they're not eating food that's going to make them sick. This also gives us a better place to put our data. We can have a place that we can look at it, we can analyze it, we can show that what we're doing matters and that we are protecting Kentuckians. Also within REDCap, there's the ability to produce a risk factor analysis study. Like I said earlier, we want to know that what we're doing matters. Also, this will reduce the phone call complaints to the local health departments. They get a lot of calls about a lot of different things, and this is one more thing that we can take off of their plate and have put into a system that they can easily see, instead of trying to scribble down notes super quickly and then maybe that post-it gets lost somewhere, because like I said, they're getting calls about all kinds of different things constantly all day long. And if we have a system in place for someone to write that down, we can go back and review it and compare it to other data that we have to make that we're addressing the situation.
Yeah, and just to highlight a couple other things that Brooke has mentioned here too. I think the really important thing here is having a centralized system is vital to really understanding the health of the state across the state. Right now, if someone wants to leave a complaint, they have to call their health department, and each health department is going to collect different information, different variables. It's not going to be comparable from one county to the next or one region to the next. We know outbreaks don't fall within county lines. They go across county lines, across region lines. So having something that can be the same data collected across the entire state is crucial to really making sure that we know what's happening on the western half of the state is the same thing that's happening on the eastern half, or vice versa. Also, it really is important for the retail program standards too. It helps us meet standard 5 of the retail program standards, and it helps our local health departments if they ever wanted to enroll in those. they're going to already be meeting standard 5 by default because we have a statewide system that's available to them. All right. We'll go to the next slide. Okay, so for this one, I wanted to highlight what the timeliness looks like and kind of how a typical timeline looks like for an outbreak investigation versus how it can look with the food complaint system as well. So I'm going to give kind of a scenario here, and it's a very conservative time scenario here, so keep that in mind, but we'll go through this real quick. So let's say on day 0 that the patient eats at a restaurant, and then in 1 to 3 days, they begin feeling sick. That's a pretty fast onset for an illness, so it's probably something like a toxin, most likely, but it's possible that someone would get sick within 1 to 3 days after eating. If they follow the traditional trajectory here, they're going to go seek medical attention in 2 to 5 days potentially. They might get lab tested if the doctor recommends lab testing. And if it's a reportable disease, then epidemiology will get that report from lab and they'll begin investigating. And if they begin finding a pattern there, we're now kind of a week out or 10 days out from when that person initially ate. Food safety might be involved in getting corrective action into that restaurant that was identified from the patterns. So now we're up to 2 weeks past when the person got sick, and more people are probably getting sick if it's an outbreak situation. So we haven't really done much to resolve the situation within 14 days even. And so food safety can't get corrective action into that establishment for about 10 to 14 days after the initial onset. But during that whole time, people are probably still getting sick at that point. This is kind of a traditional trajectory for how an outbreak response would go following the whole lab testing and epi investigation sort of scenario. On the next slide, I'm going to show what it would look like with a food complaint system and how this can really improve the rapidness of our response to this. So same situation, they get sick in 1 to 3 days after eating, but now maybe they didn't even seek medical attention. Maybe they went straight to the food complaint system that we have in place, and they can log that the day that they get sick now. So they've logged their food complaint within 1 to 3 days of initially eating that meal. This is also great because not everyone is going to seek medical attention. So we're going to miss a bunch of people that were sick who just didn't feel sick enough to go see their doctor. Having a food complaint system, we still get people that had mild illnesses, which is great because now we have more information to go off of. At the same time, after 1 to 3 days, they log their complaint. Now both EPI and food safety can investigate these reports at the same time. So we're doing simultaneous investigations. We're not waiting on one or the other to get results before we can make action. And now we can get corrective action into that restaurant in a much faster timeline in a much quicker way, and potentially prevent other people that were eating at that place from getting sick as well. I really like these slides because I think it highlights the importance of having something like this and how we don't have to rely on lab testing or if they sought medical attention to really understand if people were sick or not. All right, I'll turn it over to Brooke for the last couple slides here.
All right, so we didn't want to make this system and then have nobody know about it. What's the point of putting all of this work into this system if we don't tell people about it and get them using it? So we wanted to have it linked right on our food safety branch main page. If someone's just looking around on the public health website, they'll see it there and then they'll be aware. We also had funding for marketing, which is a very important aspect. Like I said, we don't want to have the system and have no one use it. So we'll be using some social media campaigns and then search engine optimization. We're working with a marketing firm to do all of that. And we really want it to be visible to ensure we drive consumers to our site to report their foodborne illnesses. Like Nate mentioned earlier, if they didn't go to the doctor and they don't have a complaint, we're never going to catch that. We're not going to have any of that data. And we originally wanted to have our own website, but we ran into some branding and marketing issues. Did you know that Food Network has a show called Food Detective? We didn't want to run into any legality issues there. So we ended up scaling it back and we're going with the very simple Kentucky food complaint system. So I mentioned in a search engine optimization for greater visibility as well. That means we will identify keywords and we expect people to type into Google, like if you're sick or anything like that, and then they will be directed to our site. We'll be the top search in Google. We also with this, if you have your GPS location turned on your phone and Google knows you're in Kentucky and you just type in illness, food, something like that, it's going to bring up the Kentucky one because it knows you're in Kentucky. So we're really doing our best to heighten the visibility of this because we want people to know that it's a resource for them to put in their complaints and that we'll be able to do something about it if we have this data. Next slide, please. So our progress and timeline, like I mentioned earlier, we ran into a few snags with some branding and marketing issues. So it did take us a little longer than we had anticipated, but we are expected to launch sometime in the fall of 2022. Fingers crossed next month. Don't hold me to that. I'm sure there's going to be a bump in the road and that won't happen like always. And we're still working with our branding and marketing team to make sure that we're having the highest visibility we can to people who just type simple words into Google. We want them to see us at the top of the page, click it, and be able to easily complete that survey on their computer or their phone. And we already have our automated alerts to the local health departments and the jurisdictions. They are already set in place. So we're kind of keeping our URL secret right now, so someone doesn't jump in there and start filling out stuff just yet before our local health departments know that this is coming. But they do know it's coming. We're going to be sharing our guidance document that goes through all of our suggestions of what to do if you get a complaint, how to tell if a complaint might be bogus, that kind of thing. And yeah, we're really excited. We're so close to it launching, and this was all kind of Nate's brain doing all of this, and he's moved on, and now I'm taking it over, so I get to do all the fun stuff and work with the data. But I'm very excited about this, to have a centralized place where we can help our local jurisdictions and not have this fall on them, and we can have a place to look at all of that data and really catch something before it becomes a bigger issue.
All right, so we're going to wrap up real quick here so that I can get into the demonstration, because I know we probably have a lot of questions to answer as well. So having a centralized system is really important. Of course, we've already talked about that. If you want to plan on implementing a process like this in your jurisdiction, definitely start early, because it does take time. If you have any kind of bureaucracy you have to go through, it takes some time to get those things approved. I really wanted to highlight too that it's important to have this system, but you also want to make sure that you bring all of the stakeholders to the table when you implement something like this. So we don't want to catch our local health departments off guard with a system like this. So what we did, we set up regional meetings with them, and we went across the state, kind of we called it the world tour, where we went across each area of the state and had a meeting with each of them, where we could have the ones that were close could come in person and see the presentation about it. The ones that were semi-close could join a Zoom call and hear about it. But we wanted to make sure that everyone was aware of this system and they were all on board with it, as well as get their input into the system. So when we were doing these presentations, we would take notes of things that they said that they would like to see in it, and we would update those in this REDCap system to make sure that everyone felt like they were part of it and they wanted to contribute to it. So I really recommend, if you're a state system, involve your local health department people, anyone that you can, and get them involved in the process. That's going to build their sense of belonging into this system. And with that, I think we're going to move on to our demo, because I want to save about 10 minutes for questions. So let me pull that up here. Can everyone see the REDCap page here? Okay, great.
We
So,
can. Is there any possibility to enlarge it a bit?
Yep.
Yeah, that's better. Thank you.
Is that
Perfect.
better?
Yeah,
All right.
yeah, great.
So when you go to the page, you'll end up on this first page right here that has kind of details about the system. So you can leave a complaint about a food-related illness, something that you think made you sick, a food or food product issue, such as if you found something in your peanut butter, maybe you found like a piece of metal in your peanut butter, you could leave a complaint about that even if you weren't sick. And any other kind of issues you saw, maybe you saw a restaurant employee leaving the bathroom without washing their hands, you could leave a complaint about that. So our system is very comprehensive. It's not just about something that made you sick. It could be about a variety of things, food safety related. And that's really what sets this apart from some other systems, is having all the variety. That's also why we built a lot of branding a lot of branching logic into this, because You're not, just because you have a food illness doesn't mean you need to leave something about a food complaint product or something like that. I'll just go through this quickly because we have about 5 minutes until questions. We have a privacy statement here. The first question is, what's today's date? It's going to automatically fill that in though for you, so you don't have to worry about that. And then this is where you get into questions about if it's going to be an interview or if it's going to be a direct report. So if you're, for the most part, people that go to our site are just going to be reporting it directly. So they're going to say, I'm a member of the public reporting a food complaint. They'll click that and then they'll continue on. If someone calls their health department and wants to leave the complaint, the health department can then go to the site and they can click, I'm a public health worker completing this as an interview. And then we're going to get some questions for that public health worker. So we want to know what's their name, what's their email address, what health department did they work for, what area did they work in. And that's just so that if we need to follow up later about more details from the complaint, we know who to contact, who did the interview. I'm going to quickly just scroll down and show you how short the form is when you don't click anything, because it's actually not bad. So we have the About You section where we ask for the name and phone number, the address where we ask them what county they live in, what state they live in, what country they live in. Complaint details, are they reporting a food-related illness? And this is asking, was the food prepared fresh or was it prepackaged? And then how did you hear about the complaint system? So you can see it's really short until you start clicking in a certain way. So depending on what you click is what's going to show up. First name is required, last name is required, phone number is required, email address is not required. All the states are listed in here. So someone from other states could even leave a complaint if they ate somewhere in Kentucky. Someone from another country could leave a complaint. I'll get into here. This is where we get some more details. So are you reporting a food-related illness? If we say yes to this, we're not going to have a whole section about clinical information pop up here. So we want to know how old they are. We want to know some demographic details. Did you or the person you're reporting for become sick after eating a meal? Yes or no? If they say yes, they're going to get more questions such as symptoms down here. Fever, nausea, vomiting, diarrhea, other, please specify. If they said, did you get tested for a food-related illness? If they say yes to that, we're going to ask them some more things. Have you received the results from that test? If they say yes, now we're going to ask them if they know what their specific illness was. And if they click one of these things, we're now going to get a specific set of food history questions that they're going to be asked. So maybe they said they tested positive for salmonella. A lot of people know what that is. And if they said yes to salmonella, we're going to ask them for meat questions. We're going to ask them for dairy questions, ask them for fruit, produce, as well as vegetables, produce, and prepackaged foods that could potentially contain salmonella. So but you can see how the survey gets bigger and bigger depending on how someone answers these questions. That's just related to the clinical side of things too. So I'll click out of this and I'll go down here to the actual, let's see. Sorry, I'm scrolling very fast. This question right here is going to determine if they got a retail food product or a manufactured food product. So if they say the food was prepared fresh, they're going to get retail or restaurant questions. And so they can begin listing things like, what was the restaurant name? Do you have a loyalty or rewards card with them? Can you give us that loyalty card? Which county is the establishment located in? This question right here is going to trigger the alert. So if I said Barron County, the person from Barron County is going to receive that email. If I said a different one, someone else is going to receive that email. Provide the address, including any landmarks that we can identify. So maybe if they said McDonald's, there could be 5 McDonald's in this county. So we want to know exactly which one they're reporting, as well as any landmarks, we can identify that. They can select which kind of restaurant they ate at. Could be any of these things or none of them. Did they dine in or do takeout? Did they do any kind of meal delivery? What date and time did they eat there? Describe all the items that you had with them. We also ask them if anyone ate with them. We look for well or sick companions as well. So like this means, did someone not get sick? And if they say that, we want to know who did not get sick and what did the person who did not get sick eat. If they say they had people that also got sick with them, we want to know how many people did get sick and what the other sick people also ate. and then any other meals in the last 7 days that they can list that we asked them for here as well. We can also have them upload a photo of their meal, upload a photo of their receipt, upload any additional files for the complaint, and any other non-home prepared meals that they've had, they can list here, additional comments, and how did they hear about the site. So I just did a really quick run through of the retail questions. There's a whole other set of questions for manufactured food. I don't think we have time to go into those, but basically if they had clicked the food was already packaged or processed, then they're going to get a manufactured food question set. Other than that, I think we can go on to questions now probably.
Nate, I went ahead and pulled all the questions out of the chat into a Word document. If you want me to share my screen really quickly.
Sure.
Thank you for capturing those, Brooke. Yeah, there were a lot of great questions that came in through the chat while you were presenting. A lot of interest in this system, and thank you both for presenting. And I should let everyone know that Nate and Brooke came on board to present this topic only 2 weeks ago. We had a last-minute adjustment to our agenda, and they were very gracious to come on board with very short notice. So I do just want to give them some recognition and some thanks and applause for being so willing to come on and share this system with us. And I think it's a really great system. Really excited that you guys shared this with everyone. It looks like there's a lot of interest in it. And so let's get to some of these questions. Brooke, are you able to zoom in on your window a little bit? You can see. There we go. So the first question was, is it possible, and a lot of thank yous coming in through the comments if you can't see those. A lot of appreciation to you both. First question, is it possible to share these procedures and documents with us, even though they're lengthy?
Yeah, I mean, I think we could, I don't think we have time to share them in the presentation right now, but I think we could probably share them we usually share all of our documents on Food Shield if your jurisdiction uses that system. And we can probably put something on there or potentially share it with the retail seminar folks.
And I'll make sure to put all of our contact information in the chat as well, just so if you're not able to receive or find them on Food Shield or elsewhere, you can reach out to us directly and ask for those. I will say we're doing a little tweaking on the guidance document just to make sure that everything is good to go before we launch, but we're almost entirely finished with it, 99%.
Excellent. And I'm glad you mentioned Food Shield, Nate. So yeah, it's a good reference to the Program Standards Resource Center there in Food Shield that can be utilized for sharing resources such as this. So thank you for that. Another great question, is this only for food, or can this system be used for other human health hazard or environmental health complaints?
Yeah, so this one is specific for food. It's going on our food safety branch website. But it doesn't necessarily have to be a food illness. It could be something that they found in their food or something like that. I think similar systems could be developed for other environmental topics though, such as pools or septic systems. Other things could also be included in this. But not, I think this one needs to specifically be for food because it is, it would be way too broad otherwise. We'd have so many branching logic for different environmental hazards, I think.
And one of the great things about REDCap is we can pull this data dictionary and make an exact copy of it and then start from there and start editing it to make it more specific to other environmental health hazards. So like Nate said, this one will be just for food, but we definitely have the ability in the future to move this to other areas as well.
Okay, great. Question 3, I think I'm going to maybe combine that with question 5 a little bit. So because with question 5, I think we saw the answer to that in your demonstration. Question 5 is, does your system have an option for anonymous reports? And it looks like it does not. It looks like you have to put contact information in there. And question 3 is there a vetting process to weed out suspicious complaints or some way to verify validity? So is that the reason that you don't allow for the anonymous report?
You are correct in assuming that, yes. We don't want someone to be able to go in anonymously and make hundreds of reports at an establishment because they're angry about a certain thing. That's why we want the name and contact information. That also gives epidemiology the opportunity to reach out to that person and ask additional questions if needed, although this is very comprehensive. Yeah, there's not a way to completely weed out every suspicious complaint or determine the validity, but we really think having a name and contact information is going to keep the people who are not doing it for a good reason out from not doing that.
I would also add, in general, when you read someone's comments on a food complaint, it's fairly obvious if they're like someone that's just mad or someone who actually has a valid complaint that they're leaving. When they put their name to it, even more so, especially when they put their name and phone number, they're more so likely to, like, someone who was going to leave a bogus complaint is less likely to do it if they have to put their name and phone number on it. Now, that doesn't mean that they couldn't put a random phone number like their local Walmart's phone number on the complaint and then leave whatever they wanted to in there. So it's possible that other complaints could get through there, but it's less likely. And if someone did really want to leave a valid complaint that was anonymous, they could call their health department and tell them to put the health department's phone number down for the phone number and put their name as written as anonymous in the first name and last name. If someone wanted to validly leave like anonymous complaints, they could do that.
Sure. Do health departments, when they receive these complaints, are they able to see all complaints or only the ones that are assigned to their jurisdiction? And then as a follow-up to that, I guess in addition to that, will the reports they receive be the raw complaint data, or will it kind of be like a summary or cleaned up version of the complaint data?
So we are a decentralized state, so each of our jurisdictions do only have viewing privileges of their own, but that's what we do on the state side is we review all of them and find patterns, and then we connect them and give them the necessary information. But the reports, okay. The alerts that are sent out as soon as someone sends a complaint are very basic. It tells the restaurant, the location, and what, I think maybe symptoms, something like that. It's very, it's not super identifying because we don't want the patient's information to be going out through email. So the reports, they will be raw data, but we will be able to go through and clean some of that up as well and make sure that it's not just, it's here, there, everywhere. We'll clean it up before we send it to them. And that's going to be an easier task since it'll be just for one county or one jurisdiction.
Yeah, and just to add to that too, a lot of our counties, our local health departments are organized into regions as well within our state. And so some of those regions have people that cover multiple counties, and they might be receiving alerts for every county that they cover in that region. So it could be that even though the alerts are set up at a county by county level, the same person receives alerts for 5 counties that they cover, kind of thing too. So we can set it up that way, and that's how it's been set up in the past.
And another issue that we ran into is that if people want to go, or if the local health departments want to go into REDCap and view this data correctly, they have to have a REDCap account that's paid for. And there's just too many people spread across this entire state that need access to that data. So I'm going to be kind of the contact point for that. So I can pull the data that they need and get it to them. And with the reports we've already created, it's just a couple clicks of a button. It's really easy for me. Thank God.
That's good. I think with this next question, we saw this on the demo, but it looks like if an individual, a citizen calls their local health department to say, hey, I got sick, after I ate at this restaurant, then the local health department can enter that directly into the system themselves, or they can direct the citizen to, either way, just depending on what procedure they choose to do. Does the system make recommendations to seek medical care and get tested?
Yeah, we do. In the very top kind of instructions before they get to the questions, we say something like, if you think something that you ate made you sick, or someone else you know is sick, please contact your doctor and then fill out this form. We want to make sure that if they are sick and they do need medical attention, that they know that they should seek that first.
Okay, good. And do you share this information with healthcare providers?
Oh, sorry, yes. So our plan is actually, we want to do some branding with it, marketing with it. And we would like to put like different kind of handouts or things like that in our providers' offices. Like they could have like a magnet hanging on their shelf or something like that, that if something they ate made them sick, they could scan a QR code or something like that in the doctor's office. There's also some other targeted places you can put things like that, such as in like the Pepto-Bismol aisle of Walgreens or something like that. Somewhere that we know people who get sick would often visit, put like marketing materials in those areas that they can scan or find a short link that they can go to really target that area.
And marketing is still an ongoing thing that we're working on. So any suggestions for that kind of thing, we would gladly take them. We have talked about disseminating physical copies describing what this system is to our local health departments so they can give them out to their partners, post them up on poster boards wherever they see fit.
Yeah, some feedback in the chat about that QR code marketing will be great. Actually, to me, that sounded like a great idea too. Somebody is asking if they heard correctly, if the person does not get tested, that the system does not collect meal history. Is that correct?
Yep, so I can answer that one.
I
So
don't
yeah,
want to miss
if
the
they
first
didn't,
half of it. I think it sounds like the sound of it there.
sorry. So I was just gonna say,
Go ahead, Ed.
if they didn't get tested for a disease or for a reportable illness, we're not going to ask them the complete meal history questionnaire. So those meal histories are actually taken from the foodborne, waterborne questionnaire that our epidemiology team uses when they're investigating reportable diseases. If someone didn't test positive for one of those reportable diseases, these questions aren't as applicable, and it's just going to add to the length of the survey. That's really maybe going to stop people from completing it. We really want that information if they were one of those reportable diseases and they're one of our cases that we have to investigate. What that does is we can then share the information with our epidemiology team, and they can skip those questions when they have to do that foodborne, waterborne questionnaire with the person. So it's really saving time for our epi teams and not giving the full set of questions to someone who maybe doesn't really need those questions.
And that's not to say we're still collecting data on the complaint, the specific establishment and what they ate there. We're just not getting the food history of everything else 3 to 5 days leading up to that illness. So like Nate said, if they're not diagnosed with that illness, the epi team isn't going to be able to do that questionnaire, and that data, while it is meaningful, it is not as meaningful in this situation for us. We want to know about that complaint so we can send that to our local health departments and their environmental team so they can go check it out if they see it.
And the survey does still ask them about other meals that they ate, but they'll just list those out in a notes box instead of in a kind of that yes or no questionnaire kind of situation. The yes or no questions directly align with what our epi team needs for reportable diseases, which is why that's specific to that meal history.
During the system development, and forgive me if I missed this part because I was trying to take notes while you were talking, but was there planning considered for future phases of the development of the system, or like additional modifications or updates to the system during the initial planning phase?
Before Nate starts, I'll go ahead and say he did all kinds of meetings. His little folder for this, talking about all the different jurisdictions and counties. He was doing so much reaching out to the local health departments and getting their feedback and their suggestions, comments, concerns, all of that before I even came on. So this development was wonderful. And Nate, you can talk more about it, but what he did was great.
Yeah, so we had quite a few different rounds of development for the system. We initially started, Virginia Department of Health shared their data dictionary with us. So we built this on the basis of My Meal Detective. That's kind of where our baseline started. And then we kind of tweaked it and modified it to what we needed in our health department. So we started with our retail program and getting what they needed from it. And then we met with our manufactured program and see what they need from the system. And then once we felt like we had a really good, solid baseline to build from, we started bringing in our local health department partners to planning meetings and adding questions that they thought they wanted to see, and what did like bringing in different stakeholders, epidemiology, what do they need from this? What does lab need from this? Like basically building the team up and starting from like a baseline process and working our way up to the bigger picture, but making sure that everyone felt like they were stakeholders and they were sitting at the table throughout the process was really important to that. And our partners at local health departments felt really involved in it, I think.
We were, Nate was really, and I am in a unique position because we're the rapid response team. I'm the new one, he's the old one, but we were in a position because we have to know all these people to get the team coordinated. So we were able to reach out to all of our contacts and bring them together and ask, what do you need from this? What should we do? How do we make it better for you? So that you can make informed decisions to go out and either look at this place, look at this food, go teach hand washing, go teach proper hot holding, anywhere that we want them to be able to make informed decisions.
Excellent. Well, thank you both for your presentation today. It was very informative, very excellent information. And again, we appreciate you both for coming on board with short notice. And I'm going to turn it over to Carolyn. We've got one more presentation on the agenda to wrap us up for our central breakout.
Excellent. Thank you so much, Becky. And thank you, Brooke and Nate. That was a fantastic presentation. Thank you so much for your willingness to be with us this morning. Yeah, fantastic work all around. All right, folks, it is time for our final session of our breakout today. And something that we used to do in the former Central region during our regional seminars, what was an open Q&A around the food code. And we did this last year in virtual space and it seemed to work out pretty well. So we wanted to bring it back. So what I'm going to do is bring on a legend in our office, and that is our retail food specialist, Greg Abel. He is one of our absolute experts on this topic. And so what we're going to do is have an open session, open forum. We did have some questions submitted ahead of time from some of our state, local, tribal, and territorial partners. So with that, Greg, are you ready to go?
I am ready.
All right, then I will turn it over to you.
Okay. Thank you. All right. Am I live, Carolyn?
You are live, coming in clear.
Okay, very good. All right. Well, I want to welcome you guys to the Central Breakout session. I'm Greg Abel. I cover retail food specialist. I cover North Dakota, South Dakota, and Minnesota. Been FDA a long time. In fact, half my life. I've worked more than half my life. So that means I'm 44. I'm just kidding. Older than that. But the food code interpretation session has been a staple, like Carolyn said, for the Central Seminar for over 2 decades. It was first introduced in 1999. And that's like 23 years it's been in play. That's the same amount of time you can conceive, bear a child, and raise that child to adulthood through college. So we've been doing this for 23 straight years. So this session is really meant to be interactive. I'm going to provide the opportunity to ask some interpretational questions on the food code. It can be used, questions can be in inspection techniques, inspection report marking questions, and of course, anything on standardization, okay? So how we're gonna work it, since it's virtual, is you can raise your hand and you'll be recognized and you could ask that question. Or you could also put your questions in chat, and we have some of the food specialists that will be monitoring the chat line, okay? There is a few ground rules for this particular session since it is interactive. So round rule number 1, be open to hearing another's question. Listen with an open mind like you would a friend. It's okay to disagree. However, do it politely and openly. We're all colleagues, so let's all respect each other. And this year, smoking again is allowed. Unlike past years, we would not allow smoking since we're in person. But since we're virtual, if you choose to smoke, you can smoke. And if we don't get to your question, you can always write it down and send an email to me or your retail food specialist directly, And we will get that question to your retail food specialist to get answered. Okay, so I could be the contact person, send it to me, and I'll divvy it out to the proper retail food specialist if your question doesn't get answered or one pops up. Now, with this session, I've asked some questions for ahead of time. And that doesn't necessarily mean we're going to get to those questions, because I'm going to use those for fillers in case there's some dead space. All right. So the main goal is to have you guys ask the questions live and interact. But if I need some radio coverage, I'm going to ask some of the questions that were asked to me ahead of time. I do want to introduce to you, this is the Central Seminar, covers, it's a ghost region now, but it covers many, many states, 15 in DC. So I want to let you know who's on board here in this session. We have Kenya Moon, she covers DC, Virginia, and Maryland. We have John Tran, he covers Michigan, Ohio, West Virginia. Carolyn White, she covers Illinois, Indiana. Mike Nordos covers Wisconsin, and then over to Iowa. Becky Steiner covers Kentucky, and also Kansas and Missouri. And Valerie Potapsang covers New Jersey and New Hampshire. Tom Nerney, who's not here, and I don't think Valerie's here either, he covers Pennsylvania, plus Vermont, Rhode Island, and Maine. And then Kwanzaa Duggins, she's got Delaware, and she's located in Oklahoma City, but she also covers Arkansas and Louisiana. All right. So with that, we will start the session. Do we have anything in chat right off the bat?
Greg, we do
Oh.
have a question in chat. So first question is coming in from Dustin Hampton. It says, I have heard rumors that the FDA food code will be updated to remove the 100-degree Fahrenheit temp requirement at hand washing sinks. Is there any merit to this?
I have not heard that, but it could be a issue that's presented at CFP. I think in my memory that was proposed at one time, but I think it stayed at 100 degrees. And that doesn't mean you have to wash your hands in 100 degrees. That just simply means it's got to be able to provide water to 100 degrees at the faucet, right? So some studies showed that just running water, the agitation with the detergent is the biggest thing to remove soil and bacteria, and then you rinse in water, and that removes all that invisible soil and bacteria, flushes it away, and not sterilization, but removes the load. And the reason hot water is beneficial in a restaurant or warm water is because warmer water will solidify fat, right? If you have hamburger grease on your hand or any food fats, and you use cold water and detergent, it doesn't quite remove that film. So warmer water is a better catalyst to remove fat. Okay, next question. Oh, Kansas City has lowered it to 80 degrees.
All right, we do have a hand raised. Yusto Garcia, Did you want to ask your question?
Yes. Well, since we is open forum and standardization is part of what is covered, and we had such a great presentation earlier. I'm a fan of standardization, but I really think that the current version of what needs to be covered and under standardization may impossible for inspectors to conduct actual and a standard inspection in the day-to-day. And I'm just wondering if there is any plans to review that process in a way that can cover what is critical to a food operation, or the aspects that are more likely to actually get somebody sick. In other words, if we plan to kind of shorter that standardization to make it more about those risk factors.
Well, thanks for the question. Yeah, that's what standardization is about. It's supposed to mimic a real-time inspection, right? So it's really risk-based inspection. And maybe, I guess, how we do it from FDA to state is we look and focus it on food flow and the risk factors and asking questions and finding out where the risk factors are not in control, and then where they can be better, right? Where they can be improved to try to get long-term compliance. So in order to do that, we really have to understand food flow from in the door and out the door, right? Because look at the food services changing. We have all these ghost kitchens and foods delivered to consumers in different ways now. So it's key to understand total receipt, where you're getting the sources from, how it goes through the process, how it's made, the complete process. And sometimes I think too, what I standardize around the country, and to maybe help your question, is sometimes we shortcut that understanding of food flow and we find a violation, we mark it, and then our mind moves on to something else. But it's really important to understand the complete food flow and to understand what risk factors really out of control, so we can understand how the establishment needs to put it in control and get that long-term compliance. And the standardization process should also focus in on, how the candidate communicates, to withdraw that information, to discover the flow, and also corrective action, right, before we leave. Okay. So maybe we just keep working at improving it from federal down to state down to local, and keep focusing on that risk-based approach so everybody can get caught up. All right. Thanks for that question. Is there another one?
Okay, Greg, we have a question in chat from Doreen Byer. She says, I have 2 markets that prepare ready-to-eat meals. Could you provide guidance on how prepared foods are to be date marked for customers who buy this type of product from a restaurant? Consume by date, sell by date? What is the most transparent way for the consumer to understand?
Well, there's no regulation to say how that should be put on there. So at retail establishments, where the establishment is actually making the food, right? And there's date marking that's required, 7 days, right? And that's for ready to eat, temperature control for safety foods. And there are some exemptions, right? We know processed deli salads from a manufacturer do not have to be date marked. We know hard and semi-soft cheeses don't have to be date marked. We know pickled herring doesn't have to be date marked. So there are some exemptions because it's not a listeria. The risk isn't there. But when it comes to, like, you go to the grocery store and you're making your selection off the shelf and it's salad dressing and it says sell by or used by this date, keep in mind that's a manufacturer best quality or best used by date. It doesn't have anything to do with food safety. And I'm going to touch on that part later. That's basically a quality date. So even you have to understand what that date means. That manufacturer's putting that date on there. But once you open it, that cover, that date goes on the wayside. So the manufacturers put that on there first, how long it could be on the shelf for their control, and somewhat of an idea how long it might last in someone's refrigerator. So it's strictly a quality date. Then the question comes up, well, how do you know if it's for food safety, if this dates are for food safety or not? So I have, this actually was a preloaded question that came up as well, the same one. It's like, how do you know if those sell by dates are actually food safety dates? And I cannot for the life of me, in my 32 years, think of an example where I'd go to a grocery store, pick something up that's acidified or low acid canned food that's out at room temperature packaged, where that date is based on food safety if it's at ambient, right? So I do have a few cases where it's refrigerated food that have a use by date. Again, some of those dates are quality, but those foods are very high or more perishable. And what I've done to find that out is to actually call the manufacturer and do some research and determine what that date's about. Does that answer that question at those 2 markets?
I think there was also part of that question was talking about restaurants. It was, foods made on site, selling pre-portioned leftovers, if you will.
Yeah. So if you're making a ready-to-eat food, if you have chili, you cook chili up, you put it on the hot buffet, it gets served, you have some left over, you save it. Then that's where the date marking for listeria control comes into play, right? 7 days. And then they should either use it up in those 7 days or discard it. And if they're making a sandwich, if let's say it's a deli, they make a sandwich, and that tomato, lettuce, sliced meat that they slice, the day they make that or open those packages to make that is 7 days for date marking for control of listeria. But now if that lunch meat and that tomato was sliced 3 days earlier and they made the sandwich on day 4, then they only have like 2 more days for date marking.
Hey, Greg, it's Mike. Can I jump in a little?
Please do.
So I think part of the question is talking about, you know, how you and I have seen those prepackaged meals. All the grocery stores are doing it because people like me don't cook, right? We pick it up on our way home. So yeah, when they're selling a prepackaged meal, whether it be their leftover chicken, whatever it is, it gets 7 days for them to sell it. After they sell it, there's no responsibility on them to mark a date on there, right? So up to that 7th day, they can sell it, but there's no marking that they have to do for the customer as far as how long the customer has. They just have to have it off their premise in that 7 days. Correct. So I think that is
the clarification.
The last part of that. Yep. Thanks.
Perfect. Thanks. Yeah. Any retail food specialists too, jump in like Mike did. That's part of the process here. I forgot to mention.
Sure. I did want to follow up though on the hand washing sink question, because that was an issue that was submitted at last CFP, I believe. That was issue, let me check, 27 in Council 3. FDA did accept the issue and is currently under review. So
is that the temperature?
Keep everyone, yeah, okay. Exactly. So yeah, for that hand washing sink temperature, that is being reviewed for potential inclusion in the food code to give folks that background.
Okay, thank you, Carolyn.
Absolutely.
CFP was really weird this year being virtual. It seems like for me, I couldn't get tapped into all the information, right? Listening on a computer versus bouncing around to different councils and networking with people. Yeah, good. Thank you, Carolyn.
Absolutely. And then shifting gears back over to date marking and some other questions. Dominic Miller is asking, Greg, can you address infant formula dates?
Absolutely. Those dates on infant formula dates and medical food are required by FDA to have an expiration date. It doesn't mean if they're held for sale at retail that by that date that food becomes adulterated. That's the improper mark. Okay, I think years ago, 28 years ago, 30 years ago, if you saw baby food, baby formula, or medical foods past the date, they got debited as an adulterated food, and that's not the case. So those dates are required to be put on those foods because that person, that adult, or who's ever taking that product and that infant are relying on total nutrients to stay alive, right? So those dates are required by Food, Drug, and Cosmetic Act, but if they are expired, it does not mean the food's automatically adulterated. Industry just has to do their research to figure out how long those nutrients stay viable in their product, and they figure out the date that they can guarantee it to, but it doesn't mean they're adulterated. So don't mark that up. Just encourage them to take them off the shelf because they will get credit for it by those manufacturers. I'd encourage them to take it off the shelf, but there's really no debit about it. To call it adulterated. Keep in mind in the food code, when you read the FDA food code, there's certain words that are capitalized in small caps. And so when you see that in text, that actually means that there's a definition. So adulterated is defined. So you have to go back to the definition of what it means in the food code. And adulterated means it has a substance or bacteria or something that can cause harm. So to call something adulterated, you really, from a regulatory side of it, we have to prove that it's adulterated, and that requires sometimes laboratory analysis. So you can make a legal charge against that. Does that make sense? Okay. As you see the chat rolling, I can't keep up with it. So.
It is. That's okay. We're keeping track of it for you. So.
Good.
All right, so we had a question that came in about Table A and Table B. So when referring to the TCS versus non-TCS determination within Table A and Table B, In table B specifically, that unpackaged, does this include product that was in table A that started out commercially packaged that has now been opened? Or is it reference to product that is never commercially packaged, like product in a restaurant?
Well, table A and table B are going to be based on foods prepared at retail, right? And so we know that if we're making foods or preparing foods with no heating, we're going to use table B to determine if that food needs refrigeration, right? And for table B, we can be a little more lenient because if we're going to cook food in the restaurant and package it right away, then our pH and water activities can be a little higher and still be non-TCS because table A controls spore formers. Table B controls everything else from vegetative cells. And so we know like Listeria and Salmonella and some of these others can grow at lower pHs. But when you heat them and then put a cover or package them, those vegetative cells are no longer there and they're protected from recontamination. That's why you have table A. So I'm not sure if that answered the question specific enough or what was in that person's mind or where they were going, but that's the difference between the tables. One's controlling vegetative cells primarily, another one's controlling spore formers. And I would say that table A more links to low acid canned food regulations, right? Because in low acid canned food, anything below 4.6 is in a can is fine.
Okay, Greg, I think Tracy, she's the one that asked the initial question, has her hand up. Tracy, do you want to follow up on that?
Yeah, thanks, Carolyn. Thanks, Greg. Yeah, Tracy Michelson from McDonald's Food Safety. So I guess what we're asking the question of a lot of times is we'll come out with a limited time product that might have a question around the food safety, the TCS versus non-TCS. So in this instance, it was a bakery item that we got in commercially processed and packaged. We remove it from the package, move it into like a bakery carton, and then it gets sold. So we're just trying to understand if we're using the table, does that refer to the products that we're bringing in that our suppliers, our manufacturers had made for us versus what we might be making in-house. So, and this will help probably across the board for other products we have, as well as this current bakery item that just rolled out.
Yeah, I think if you're bringing food in, you're taking it out of the package, then it becomes a table B type thing, right? Because now there's been exposed to the environment. So now the pH requirement, you'd switch to table B if you're going to be adding it to another. Does that make sense?
Yes, absolutely. That's clarification. Clarification we were looking for.
Okay, good. Because someone else from a different state, actually, that was one of the other questions. It's funny that you guys are thinking all the same across the country here. Good. The reason we did this is because, potentially hazardous food, the old definition was so archaic. It was either this water activity or this pH, and that's it. And we know that there's foods and different hurdle effects of food manufacturing that, well, wait a minute, if you can adjust these in-strength factors, that we're going to control bacteria. So this is kind of trying to get more looking at food a little more carefully and really determining what the risk really is. But to finish up, Tracy, on your question, what's so important in your situation, bringing foods in from suppliers, is understanding, once it comes into the establishments, is understanding the flow and where it goes and how it's used, how it's opened, if it's incorporated or not incorporated, or stays packaged, blah, blah, blah. Okay, I hope that answered that question.
Yes, thank you.
Yep.
All right, Greg, next question. If daycares were to serve scrambled eggs, are we requiring them to use pasteurized eggs?
Good gravy. I'm trying, that would be a highly susceptible population. And how are they serving these scrambled eggs? Are they cooking them and serving them, or cooking them and holding them?
Maya, did you want to come off mute? Oh, yep, she says yes, cooking and holding.
Oh, then either a HACCP plan or pasteurized eggs. So this scenario kind of comes up a lot, maybe in assisted living or nursing homes. Like, I'm going to cook scrambled eggs, and I'm going to cook them for many people right now. And it's going to be cook a big batch, and it's going to be served. And so think about logically what the risk is. What, you want to use pasteurized eggs to reduce the risk. You don't want to pool eggs, because that's where we had problems with salmonella growing. If one of those eggs had salmonella in it, and that container just stays there pooled all day, then they pour the container into the frying pan, then they use the same pan, you got the egg residue. So, I mean, I would think about if I was doing an inspection and they had 7 kids there and they cracked 7 eggs and they cooked them thoroughly and served them right away. I mean, if you hit the temperature, it's going to be safe. But if they're going to cook them and then hot hold them for some time, then yes, pasteurized eggs the way to go, or a HACCP plan. Does any other retail food specialist disagree with that or have something to add? Okay.
All right, we have, okay, hold tight. This is a long question from Sandra. We are a local health department in Texas who, by adoption of the TFER in 2021, has adopted the Food Code 2017 version. With that said, we are also working on incorporating an electronic health inspection system, but need assistance in figuring out a point system for the new 56 inspection item form. The reason we need to come up with a point system is that our citizenry wants to see a grade, which we would then post. I've spoken to DSHS, and apparently it's up to us. I still would like some assistance, especially with our discussions on standardization. There's got to be a way to assign points to each of those 56 items and not just be left up to us to come up with something that works for our jurisdictions. Thank you in advance for any assistance.
Yeah, so FDA doesn't, in my knowledge, doesn't have that. And it would just be the individual's opinion or my opinion, what I think. But there are jurisdictions out there that do provide grading and points. So perhaps Texas can reach out to their other local agencies or their retail food specialists to see if they can find out which jurisdictions have such grading systems. Or maybe there's someone on this forum in this seminar that has grading systems. Like I know Nebraska, Lancaster County, they have a color coding system. So what you're explaining, they have something to generate a color for a grade, right? So there's some quantitative numbers and things they've done to actually generate a score and or a grade or a color. But FDA specifically, we have nothing specific or recommend. So does that help? Okay,
looking in the comments, Amy says that Kentucky has points assigned. I had someone else message me and says that Guam has a point system.
Okay.
So maybe reach out to your retail food specialist and see if they can point you in the right direction as far as some connections for folks who are already doing some version of grading.
Yes.
All right, Greg, next question. Are you ready? Are we going too fast? Or are you good to go?
No, I'm good to go.
All right, next question. How does 3-60311 in the food code, that's our consumer advisory, apply to a product such as cold smoked salmon, which is prepackaged from an approved manufacturer who is operating under seafood HACCP? The Seafood Hazards Guide does not require any type of advisory labeling to be done by the manufacturer if this product is raw and ready to eat. In this case, is the retailer required to add a consumer advisory for this type of product?
So this is a cold smoked salmon that's coming in from a FDA regulated firm?
Correct.
Well, gosh, that comes up every once in a while. My answer is no. It would not be required to be consumer advisory because FDA requires seafood producer processors to operate under HACCP. And under HACCP, you have to reduce those likely hazards. So if they're going to cold smoke and that cold smoke temperatures are different than what the food code requires, because we don't have cold smoking requirement temperatures and times and water phase salt in the food code. So it's already coming in ready to eat. So that should be safe to eat. I guess if it wasn't, I don't know, and I haven't heard how FDA seafood HACCP would allow something to go out with no pathogen without a warning. But if you're making Gravix or something inside your establishment at a retail, then yes. Unless you have a HACCP plan to prove that your water phase salt is at this level, it's been brined for this amount of time, it's been cold smoked at this temperature, steady with a recording chart at, I don't know, 150, 130 for whatever the requirement. I used to do these inspections back in the day, whatever it is to cold smoke a fish to make them safe. So I say no. Anybody else in the retail food specialist world have a different piece of advice? To me, it seems like if it's coming out of an FDA plant, it's got to be ready to eat, unless it's otherwise saying you got to cook this, needs cooking or something.
Agreed.
All right, next question. Are raw pasteurized eggs considered ready to eat as far as food storage, or would they still need to be handled the same as regular raw shell eggs?
Okay, this sounds like a trick question. What way is the direction blowing, and when does the train from Cleveland leave? Okay, so I gotta I gotta digest this one. So read that again, Carolyn.
Sure. So the question was, are raw pasteurized eggs considered ready to eat? So I think it says, are pasteurized eggs, I'm guessing still in the shell, considered ready to eat as far as food storage? Or would they still need to be handled the same as our regular raw shell eggs?
So for food storage.
Regarding food storage, yes.
Yeah, they have to be refrigerated. Is that what they're getting at? It's well, if I'm getting the question right, it's like milk is pasteurized, but it's still a ready to eat, time as a temperature control for safety food. So we require it to be refrigerated, right? A shelled egg that's pasteurized, and I guess, can it be out in a shell out at room temperature? I would probably.
I can clarify a little bit.
Yeah.
That was my question. We had a restaurant and they had pasteurized eggs stored, and it was, I think it was stored above the raw meat, and they were thinking because it was pasteurized that it didn't really count as like a raw product, where if it like broke and dripped, which is why we make them store them on the bottom.
Yeah.
So anyway, because it was pasteurized, they wanted to store the eggs as like a ready to eat product. And we looked through the code and we couldn't really find anything that specifically addressed pasteurized eggs. But then the USDA, I found something that said that to them it's considered ready to eat. So that was just my question.
I guess if it's pasteurized in the shell, technically it should be fine, right? There shouldn't be any pathogens in there. It should be reduced to a certain level. Doesn't mean it's sterile. Pasteurized, they're just taking an egg, putting it in a water bath for 121 degrees for X amount of time to reduce the bacteria level. Not sterilizing it, making it commercially sterile. You know what? Can we
Hey, Greg, I can help you out. I've
ahead.
talked with Stan about this if you don't
Okay.
mind.
Yeah.
Yeah. So the challenging part of this question, I keep taking my camera off and I forget that I have the little black thing slid, my double safety, so I don't ever have it on when I don't need to. Sorry. So pasteurization, right, doesn't, like Greg said, mean it's a sterile product, right? You pasteurize milk, it doesn't mean that you can keep milk out at room temperature. It doesn't necessarily mean that it can't grow anything at that point, right? But with these eggs, the process, and like Greg said, being in the shell is a little bit different. So the guidance I've read from USDA, in which I've talked with our CIFSAN colleagues about, is that the pasteurized egg is considered a non-TCS food. So the normal, yep, in the shell. So the normal storage requirements for a TCS food don't apply. So if they stored it above meat and it were to drip on it, no big deal, because it's fine. So
the risk, thanks, Mike.
In fact, there's a lot of them don't even require refrigeration anymore.
Thanks. I've been off the grid for 10 and a half days and turned my computer on yesterday at about 7 o'clock. It's hard to get back into food safety mind. Anyway, thank you, Mike. Pasteurized eggs are a low risk. You know, I mean, if they're if they're lowering the bacteria, then the risk is lower, right? Okay.
All right, ready for the next question? We're going to shift gears completely.
But I'm going to ear tag this too. So if it comes up again. Okay, go ahead.
All right, so is there a health concern for bar garnishes? Meaning, do they need to be below 41 degrees at all times, or only if they went through a process, and do they need a date mark? And I will say to the asker of this question, Joseph, you may need to specify what types of garnishes we are talking about. Because I'm seeing folks use all kinds of cool stuff as a bar garnish.
Yeah, I think that's the key, right? I mean, you got citrus fruits. I mean, bare hand contact, you could add things to it, but they don't need temperature control. Olives, pickles, depends what they're adding. So if it's a bar garnish that is a TCS food, like, I don't know what you'd add to a drink that's TCS food, but then yes, you'd want to refrigerate that, like cream, right? If you had a cream to add to. Okay, olives, no. Olives, no. Cherries, no. Lemons, no. Meat sticks, now you're talking Bloody Mary, Sunday morning football. Mango, no. Yeah, if it's a TCS food, then it's added to the drink, then yes, refrigerate. But if you have a busy tavern or bar before a game, whatever they're doing, I mean, they could also use time as a public health control if they're pushing them out that fast, right? Someone says a worm. No, would that be a live animal or in a tequila bottle? Mike, do you remember the question that came up, the minnow shots in Minnesota? They were taking minnows and putting them in drinks, shooting them.
I do. That was a good one. Not only were we concerned with parasites, we were concerned with a couple of things. The minnow getting stuck in their throat.
Yeah.
And then it was actually illegal. We had the DNR help us out with that because the minnow they were actually using were walleye fry. So
Oh my gosh. They would get stuck in your throat because they would those spines.
Or they could actually perforate your stomach as well. There are multiple issues that made that a real bad idea.
Yeah. Good question. Good question.
All right, here is our next question. Are we seeing any momentum from a federal or state perspective of moving food codes towards leading with the 158 Fahrenheit instantaneous temperature read rather than 155 for 17 seconds? So pushing operators to push for that temp rather than that 17-second allowance.
Yeah, that's already in the food code. So you can go to get a 5-log reduction of comminuted meat, you can go 155 for 17 seconds. You can go 158 for instantaneous. So there's a little chart in the food code that kind of puts those time temperature combinations for that for those foods to be cooked at instantaneous. So it's in there. Does that help? And I'm trying to look it up, what section that is.
Page 85.
85. Thanks, Mike. And what are those? What's that little chart say, Mike?
It says 158 for less than a second.
Yeah. So you can cook those comminuted meat, mechanically tenderized meats. You know, those categories need a 5-log kill. So you can go 155 for 17. You can go 145 for 3 minutes. You can go 140 for 1 minute, or you can go 158 less than a second. So those are the options, and it's really up to industry how they choose or want to meet those requirements. And typically, as we all know, if you're cooking a burger, you reach 155, and it's post heat rise going. It'll get those 15 seconds. And if you look at some fast food places that have conveyor type cooking, you know, pay attention to those temperatures a little more closely, making sure, you know, you might not get 17 seconds, but oftentimes in those facilities, If they're not put on, they go to a little holding stage in a tray for X amount of time where they get some more heat post heat rise. So it's really important to follow the food flow and, let that temperature rise too, because chances are you're going to go above 155. It's when you go under, right? That's a concern. So, and there's no post heat rise. But FDA is not in a position to encourage or push less than a second. It's up to the industry to figure out how they're going to meet that. Another question, any others?
Yeah, I think there's a few on there, Greg. I'm not sure if we lost our MC here.
Oh, did we lose our MC? Was there, I just kind of seen one about.
There's one about 3-502-12B allowing certain foods to be ROP'd without a variance if a second barrier is in place. Do you see that one?
Yeah, kind of, it scrolled away, but I think what they're saying is, was it with part C with raw fish? Mike, can you scroll back on that one? It was a long one. If I got it right, it was something like 3-502-12B allows certain foods to be ROP'd if a second barrier is in place. Part C allows fish to be ROP'd if frozen. But what about TCS foods that aren't fish? Can they be frozen? Actually, if they're going to do TCS foods that are not fish, then that's going to fall under 3-502-11D. So that's where that would be covered. Okay. So under 3-502-11 has all those, that has everything to do with special processing. Also, that includes temperature control for safety foods that are going to be ROP. That would fall under D. 3-502.12 talks about all those scenarios that processes that can be done without a variance. Okay. So the question says, why? Well, with seafood and fish, and fish, we know that the presence of CBOT is very, 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 very likely. And I don't have the data in front of me, but we have data to show that, of the aquatics harvested from waters, they have a greater chance of having CBOT than other foods. So when you ROP fish, you only have one barrier. We have temperature, and we have one barrier. So it's going to go to the frozen. So I think if I understand the question, well, can I do temperature control for safety foods and freeze it? And if you do it that way, you would need a variance, and it would fall under 3-502-11D. All right.
And someone said we missed a CBD question. I'm looking for that. I don't see it.
CBD?
Yeah, maybe they could raise their hand and ask it. It went so fast.
CBD, yeah. Well, basically, yeah, go ahead.
This was my question. This is Faith Ginhart with Oakland County, Michigan.
Mm-hmm.
If a facility is adding CBD into their product, like a smoothie shop, would we cite 3-202-12 additives, or would we cite 3-101-11, safe and unadulterated?
Let's see, let me go to that. Well, first of all, CBD cannot be added to any food. It's not even a food additive. It's just, you can't add it federally. I mean, states can, right? Let me go back to, I would go, what was the numbers? Honestly, I would go, when I'm dealing with dietary supplement stuff or things like that being added to conventional foods, I'm looking at basically these two pieces, 3-601.12A, if they're making claims with that. And then other one would be 3-302-14. protection from unapproved additives. But going back to CBD, that's not a food additive or a dietary supplement. So what was your debits you were going with, Faith?
We had actually decided to cite additives.
Okay.
But to be honest, you could have convinced me either way.
Okay.
I would
key
agree
is-
with that, Greg, because you've always taught me, because I learned from the legend. And the legend has always taught me that unless you can prove it's adulterated, right? So
Yeah.
I would agree with the additives, that it's not a non-approved additive.
Yeah. Yeah. Which kind of segues into another section of, the trend of adding dietary supplements to conventional foods. And what do we do there? And can they be added? And to answer that question takes a little bit of more information. We need to know what that dietary supplement is. So basically, when you see a dietary supplement being added to a food, and then on the menu board, they're talking about all the health and nutrient and cure benefits that these different dietary supplements have, that's a flag. Chances are those are not dietary ingredients of dietary supplements, that they're actually dietary supplements. So they will not be able to be added to food, okay? But it's going to depend if that dietary supplement has a dietary ingredient that's approved to be a food item, then it can be, okay? But there's going to be some complexities of different hoops and nets we have to funnel through to get there to figure if that's the case. So in those scenarios, we have to find out what the exact dietary supplement actually is to answer it fairly and correctly. But your first blush is going to be no. A lot of these things are not correct. And you would set them under those three things that are two things we mentioned: 3601.12a, 3302.14. So if you want to go more into dietary supplements, we can do that under a private chat too. So our email.
Got another one, Greg.
I think we had some, oh, sorry, go ahead, Mike.
Oh, go ahead, Kenya. I was just jumping in because I know that we've had some VPN issues. You can go ahead.
I was going to say, Carolyn has VPN issues. So
okay,
we'll jump to, I think the next one on the list was Jessica's question. What temperature does ROP cold smoked salmon have to be received and held at? Packaging says to hold at 38 degrees Fahrenheit. If the firm has documentation on the type of packaging, then is 41 still valid?
That's a very good question, because, and this came up in CFP many, many years ago. So the fish people are going to mark it at 38, but your state or local laws and even FDA food code model ordinance says 41 or below, right? So unless you have a specific state or local law that says everything has to be held at 41 or below, except for fish that's labeled as 38, you really can't hold that retailer legally to it. Does that make sense? You're going to have a law that suggests that ROP cold smoked salmon or whatever fish product that comes in that says 38 or below has to be held at that. There's really no administrative regulatory authority to debit it where it would hold up in court unless that state or local had a law that said that. Okay.
All right, seeing some thumbs up in chat, so I think that may have answered it. And we got the next question, and we've got about, I think, 6 minutes left.
Okay.
We have a question concerning bare hand contact, since yesterday was a lot of norovirus discussion.
Mm-hmm.
So Holly wants to know, why does the code allow bare hand contact plans? Why does the code provide this as an option? She says that they had a noro outbreak a few years ago with the bare hand contact plan.
Well, the history of that, probably, I'm just going to go through some history, and I'm not sure if this is the right answer, but we never had that in the food code before. So when we put that in there, can you imagine all the resistance and that happened? So this wasn't saying there's a way out, but based on science, if you look at touching bare hands with your, touching food with your bare hands is not necessarily going to get someone sick. You actually have to have transient pathogens on your hands that you transfer to the food to get someone sick, right? So in order to do that, you have to touch raw animal food that's contaminated, and then touch ready food. Or a great way to do it is through norovirus is an enteric pathogen that is so easily spread, low doses. And so it is hard not to get those viruses on your hand. If you are sick and have diarrhea, you're going to have it. So if this alternative plan, and you can think of executive chefs doing decorative increment work on pastries. If you've ever been in some of these places, I mean, they need to touch the fondant, they need to touch the food. You can't do it with a glove, you can't do it with surgical equipment. So if you have an employee health policy and it's being followed, and you're having hand washing, designated area, then the food code allows that. But it's very, very, very controlled. When we do special events, FDA goes in, and there are places where they will need bare hand contact. And so we'll put these controls or requirements in place during that special event. It's not like, oh, I can do it, I'm going to chop lettuce. If we see that, it's out the window. But if you have a pastry chef that's making something for the president or who their guests or whatever, we understand. So there's a ways they can touch food. But again, it's a very controlled situation, and you're asking them about their illnesses every day and being monitored. So science suggests that you can touch food with your hands and not get people sick, because we do it at home all the time, don't we? And if we're sick or carrying enteric pathogens or through cross-contamination, boom, that's when it happens. And norovirus is just one of those things that you get even close to it, it seems to jump onto the food. So
all right.
hey, I saw one
sorry,
thing.
Greg.
One quick question as we were talking. I saw something scroll through the chat, and I think someone put a little hyperlink to CBD products being added to food. I wonder if it was an FDA or that threw that in there for a resource, but maybe we can.
Yes, I think that was courtesy of our Sipstan counterpart, Mary Cartagena. I believe Mary.
Beautiful.
Mary's been very active with chat. Thank you, Mary.
Beautiful. I just saw something scroll by for CBD Inquirers FDA website. Okay, good. Thanks, Mary.
And let's see, while we're getting ready to wrap up, and I think Carolyn's back online, so I'll say this question and then Carolyn can jump back in. We may have missed this one earlier, Greg, but someone asked about flavored tapioca pearls or bobos. Are those considered TCS? Some labels require refrigeration and some do not.
I guess to answer that, I would have to know what the water activity and pH were of that product, right? Agreeing with the author of that question, I've seen them both ways as well. I've seen them prepackaged in stores at room temperature, and I've seen them refrigerated. So I think it comes down to the water activity and how they're processed before it could really know what it should be. Refrigerated or not. Again, also too, if we didn't get to your question and or you have additional questions, do send them to your retail food specialist, or you can send them directly to me, and I will get them to your retail food specialist, and we will get you an answer, and we'll make sure, I'll manage that. I'll make sure we get your questions answered. So I know in the past, sometimes we don't get to them, but we do want to get to them. Any other questions? Well, the nice thing is on these virtual situations, we don't get any tomatoes thrown at us, right?
No, you don't. Well, you did a great job, Greg. Carolyn, are you back with us? I don't know.
I am back.
Oh, there she is.
Yeah.
You know,
nothing like a random internet outage to freak you out for the middle of the day.
I would say a couple observations that I've observed after COVID, going out, my chair just dropped, going out to standardizing, is what I've noticed is to pay attention to is really go out there and look at food sources and with how things are changing with our food service. Look at food service. So when you're asking about food, ask the question about receiving, which is a good segue into food sourcing. Oftentimes, as inspectors or sanitarians, we go out there, where do you get your food from? Oh, Cisco or Reinhardt, or one of the big companies. But in actuality, most restaurants, they get supplies from all over the place. They're going to get their bread from somewhere else. They're going to maybe get their desserts from somewhere else. Definitely, they're going to get their produce from somewhere else. So ask those specific questions and dive in to find out where they're getting their sources. And it goes back to someone mentioned earlier today that when you're doing a foodborne illness investigation, you have to ask those questions anyway. So, ask them in your inspection. You're going to find out a lot of information and different foods that restaurant uses. And then from there, you're going to learn about more. You're going to dive more into the process of how they're making that food. And the other thing I would say is really focus in on understanding the food flow, the complete food flow of everything, from how it's received, where it's received. If you see a patty that's in a hamburger patty that's in the freezer, and you might want to ask, well, where did you get it from? Do they patty it in-house and freeze it, or are they getting it from a local butcher or somewhere else that's pattied, right? So ask those inquisitive questions, understand the complete food flow and how those ingredients get onto the finished product, because that's where you're going to find opportunities for introduction of contaminated food, or opportunities to allow food to be out of temperature, to grow pathogens. So the last year and a half when I've been out in the field, it's really focused. I've noticed we focus in more on food flow. You're going to understand where those controls are needed for that restaurant. And that's going to help the restaurant make a better food, right? We want to get long-term compliance, and restaurants are in the business to make money. They don't want to do the wrong thing, but we can help the whole system by pointing out where they can better improve their food safety boundaries, right? And some of it's so easy and common sense. So that's all I have.
So Greg, I think we had one more question. Are you going to do one more?
Yeah, we can do one more.
All right, so here we go. We are concerned about being consistent on inspections and standardization throughout the US. Why does FDA allow states to not be on the most current food code? If all states were on the same FDA food code, it would be more cohesive and easier for industry to follow. Why does FDA allow for different states to be on different food codes? This is a federal regulation. I understand this is adoption and the FDA is a reference. However, this issue could help with uniformity. Do you foresee FDA changing this policy in order to obtain uniformity?
I don't think so, because, how we are able to do our jobs, be it local, state, or federal, we need authority to do our jobs. Right? So if you're a state health department, you need the authority to have some kind of mandatory licensure of certain firms so you can go and inspect them. FDA doesn't, well, we don't have the manpower to inspect restaurants, but in a democracy, the Public Health Service Act gives us the authority to work with state and local governments, right? So, the Food, Drug, and Cosmetic Act is easy. FDA can enforce certain things because we have a federal law, but when it comes to the Public Health Service Act, that just says you're going to help the states and locals with their milk programs, sanitation, and food. So we don't have the authority to force states to adopt this. And I don't think any states would want that either, right? So the way the democracy works is here's federal government, each state's independent democracy, they have their own government, blah, 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 blah. But you're right, we do have to push, and we are pushing, and we want people to be in the most current food code. It just helps everybody around. So yeah, to force it would take Congress to do that. But FDA can't. So kind of how it works is Congress makes laws, and then they make these laws, and they have to find out, well, what agency can enforce this law, right? Like menu labeling, calorie count. Congress passes the law, they have to find out, well, what agency out there closely can make regulations? Oh, FDA can. So they give it to FDA, then we're tagged by Congress to somehow make regulations by the laws Congress passed. So, all right.
All right. Thank you so much, Greg. I think everyone in the chat has been saying it. I think everyone here can agree that this has been super helpful, really beneficial. Always good to have these engaging sessions. So it is time now is 1:25 Eastern, 12:25 Central. So we are winding down on our time this afternoon. We want to thank you all for spending your morning with us. To kind of do a quick recap, we're able to hear some updates from Director Kim Destromp. We get to learn about the exciting work Minnesota has been developing around surveying their food workers. We were able to hear different state perspectives around their standardization process. And we finished off with our good old open forum Q&A. As Kim stated this morning, this will be our last seminar breakout as the former regions. But take heart, we are going to have some excellent opportunities next year for some in-person seminar work. And I think I can speak for all the specialists here when I say we cannot wait to see y'all in person again and be able to have some of these conversations face to face. So with that, I'll go ahead and conclude our breakout. Please feel free to visit some of the other regional seminar sessions as you have time throughout the day, and please do enjoy the rest of the seminar. So thank you all so much. Have a great afternoon.